ثلاثة 4 5 2 3 2 3 4 5 علي 3 4 5 علي راح يلعب.
Assalamu alaikum. Good afternoon, everyone, and welcome back. I'm honored to introduce our chairpersons for this afternoon, Dr. Khalid Mirda. He's an associate professor and consultant of endodontics at King Abdulaziz University. He's also a chairman of Saudi Endodontic Scientific Council. And I'd like also to welcome Dr. Abdullah Al-Barkhil, Deputy Chairman at King Faisal Specialist Hospital, also a consultant in restorative and general dentistry. Welcome, please.
السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله سيدنا محمد وعلى آله وصحبه وسلم. Good afternoon, ladies and gentlemen. Today, our final session today with a number of speakers. We would like to start with or Professor Khalid Al-Hizami. Professor Khalid Al-Hizami, he's a professor of endodontic and periodontics at Riyadh Al-Ilm University. He got his bachelor degree of dental surgery from King Abdulaziz, King Saud University. He had his Master of Science at Tufts University. I know Dr. Khalid Al-Hizami personally. He's my friend. Abu Umar has a endodontic and periodontic board. He had the fellowship at the Royal College of Dental Surgeon of Canada and as well the American Board of Endodontics. Welcome, Dr. Khalid Al-Hizami.
طفوا النور شوي الإضاءة. بسم الله والصلاة والسلام على رسول الله وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. Today the topic is about research, scientifics, pragmatism in research. Probably most of you are students, either undergrad or postgrad, or colleagues in the dentistry fields or healthcare as a provider. One of the most important questions every single day we go through, what type of research we do in our fields. And I found it through the years, it is very confusing in our society in terms of what type of research we do. If we look at King Faisal Specialist Hospitals, I reviewed their reports 2016. Also I reviewed the reports by King Abdulaziz City National Guard's reports of their research. Literally almost over 90% of their research has been done is not related to the national interests of Saudi Arabia at all in terms of dental research. I have gone through their reports single research by single research, and this is where we have the confusions in terms what type of research we do. Science is imperfect, especially when you come to human beings, because when you want to do research, there's a lot of fundamental has to come into play. It's multifactorials, and you have to factor in the foundation, the logistics, the human resources, and also the stage where the research has been done. So it is, we're not a robot. We can have a fixed data and you want to try to do research. So it's a very complex process doing research. And therefore, it is important to understand how and what's the most important research of interest to our society. Type of research, they are descriptive, exploratory, and experimental. I don't want to go into deep details of these, but it is important to look at these things, quality and impacts, and it's inconclusive or conclusive data at the end. If you look at where this arrow, it shows by the WHO the importance of the implementation and planning for the research. And if you look at where we're at today, if you look at, for example, King Faisal Specialist Hospital or National Guard Hospital or Riyadh Elm University or King Saud University, each one has its own interest of doing the research, but there's no consolidated research plan to address the interests and national needs in Saudi Arabia. Again here, if you look at here, it's the same thing. These two arrows, it shows the importance in terms of collaborative work into the society. So there'll be no repetitive work, and also their data strengthen each other. This is by the World Health Organization. It's the same thing in terms of capacity, where they complement each other, the laboratory. However, if we see today, for example, Dr. Merdad from King Abdulaziz University, if he's interested to do some type of research work at King Faisal hospitals, it is hard to complement these facilities together because there is no system exists in place now. Then we come to the standards here. It's very important looking at the greater awareness, acceptance, implementation and compliance with the standards and management, the use of research leading to improved quality, efficiency, transparency and accountability. This is very important because today we have 36 universities. No single university has the GLP, the good practice laboratories we have seen today. And this is important because most of the research we do in Saudi Arabia is translational research, which involves animals sometimes from bench to bedside research. So these are the very important. Look at the priority of your community and the capacity standards, and looking at the translation research. These are all very important factors. When you look at the priority or capacity or standards or translational, these all combine together. You cannot select one and leave the others. And this is where we come the confusion doing the research in our community here. So the vision here, we have to look at the paradigm shift. If we look at dentistry 40 years ago and from today, I think it is fundamentally to look at and build what we're good at. So for example, one of the most fundamental research has been done in Saudi Arabia, dentistry community, is a research by Professor Shammari and his groups in the 80s about caries prevalence in Saudi Arabia. That research, I think, was fundamentally important. But how did we build on that research in terms of other programs in endodontics, periodontics, in terms of periodontics and pregnancy-related factors? A lot of research can be done based on that paper. So I think it is very important to look at this paradigm shift. However, just doing this sporadic research, every university, every laboratory, every research institute, they do their own interests, exclusive and isolated from the national interest. It doesn't help. The challenge in discovery and development, if we don't have these tools together combined between these universities, research institutes, between the research institute, which is very, very important, like King Faisal Specialist Hospital, King Saud University, if they don't come together with King Abdulaziz City and have their national interests together and put into priorities, put their laboratory in place in terms of coordination, it will be very hard to develop the research we're looking for to our community needs. If you look at the NIH in the United States, they look what their community needed. For example, skin cancer and other type of cancers, which doesn't exist in Saudi Arabia. If somebody does skin cancer here in Saudi Arabia, but not looking at diabetes, this is straight from the file. I mean, our priority here to look at diabetes versus skin cancer. It's more prior. So it is important to look at the national priority: diabetes, cirrhosis, pregnancy, prenatal disease, caries, smoking, complex system and coordination, funding and facilities, how to coordinate these things. I'm just going to take you to some parts of clinical research and how did we develop over the years translational research that could impact our society and help our society. I was very impressed when I came in April doing judge research in Riyadh University. It looks very simple titles. If you look at the knowledge and rationale use of antibiotics, it looks very simple by Dr. Shehri and her groups. It is important concept to look at this, but you need to expand on this research. This is truly help our community and help awareness. If you look at this research by Kanani and others, look at the xerostomia in Saudi patients. These type of research, it looks studies based, however, it is very important for our planning and awareness and addressing our community needs. Let me just take you to a few clinical research so you understand what's the difference between basic science and translational research. I'll just take you first to one of the clinical case report, I would say, if you look at here. So this is a case where it happened I did this case before. So I had badly decayed molar. Then it was broken. What I did fenestrations intentionally. I poked the roots out to preserve the buccal plate. So if this is a case, and if you look at these remaining roots here, so there's the remaining roots here complete. I did fenestrations, I poked the roots out, I preserved the buccal plates, I was able to place the implants later. So And then I can show you now more advanced research. So we came up with the buccal bone theory in 2008 when I studied the monkeys, buccal bone. So the theory we introduced was if you extract one tooth, it will be significantly different if you extract 2 adjacent teeth or 3 adjacent teeth, because this will destroy the buccal plates. Class 1, if you extract 1 tooth. So these are the cases we're going to go through. So this is the buccal plates here. This is the root, cementum. This is the buccal plates. So this is the first paper explaining the interproximal blood supply to the buccal plates. This is the interproximal bone. So you see the Havergal system here. If you imagine you bring your elevator, you're going to break this. You're going to break this, very tiny, and you're going to crush the blood supply here. Imagine you extract this tooth and this tooth, so you're going to damage the whole blood supply in the interproximal bone. And this is the blood supply going from the interproximal bone to the buccal bone. So I introduced this one. I did this when I was students at Tufts, my last year at foot shops. So this is class 1. This is Dr. Lasker. He did a dog study where you look at, if you extract 1 tooth, you see a very little non-significant bone resorption here. So if you look at, this is anterior, if you look at posterior as well, the same thing. This is a buccal bone, and this is a lingual bone here. If you look at from occlusal view, not a lot of change. There are small changes of buccal bone. So if you take this to a clinical case, if you look at this patient came and he was about to get married. So this is a tooth. So from our extraction socket theory, we're able to extract, place implants, closure, implant radiographs, temporization, follow-up, panoramic radiographs, make sure the floss goes into temporization. Then you can look at the second stage, very good amount of bone. You can see here, this is beautiful tissue here. You can see a lot of bone here. And this is because this is class 1 theory. So if you look at class 2, this is class 2. If you extract 2 teeth, it'll be more damage to the buccal bone. So Dr. Asker did the same thing in dogs. So we have done 5 papers. We used the first extraction alone, then with implants by Dr. Munir Shabib, then bone graft. You can see a lot of bone resorption anteriorly here. And it's very hard to extract dog's teeth anterior. It is very hard. And this is posterior here. You could see how thinner the bone here when we extracted 2 teeth here. Much thinner, you could see. So we look at this case here. So we want to extract 2 teeth. We knock them out. But according to my classifications, we did not want to do implants because we know the amount of bone resorption we're getting here. So what we did bone grafting, membrane, pierce the suture, then this is connective tissue graft pedicle, then this is temporization. This is post-op. At the implants, you can see we have a lot of bone now. And this is class 3. If you extract 3 adjacent teeth or more, you're definitely going to have a lot of bone resorption. So if you look at, this is the anterior micro-CT 3D, you can see a significant amount of bone has gone. It's very paper thin here at the edges. If you look at the posterior as well here, you go now to look at it from occlusal view, a very thin plate of bone here to place an implant. So therefore, if you plan to do an extractions for such amount of teeth, I think you would think twice, especially anterior regions. So this is where the canine centrals, extract them. We have pedicle attached to the interproximal. You could see there's fenestration here. This is large fenestration, bone graft, implant placed. You can see the pins, implants. There's some concavity here, which I want to augment. I was worried about. So we augmented again. We have a lot more bone for stability of the aesthetics here. You can see now we get a very nice keratinized tissue, very nice thick bone. So it is important to look at how we translate research to our clinical practice and how important it is. I'll show you a clinical case where I started my research about growth factors in 2000, 18 years ago. This girl came to me. She's 14 years old in California. So she had sinus tract, complete bone destruction. You could see. How many one of you will knock this tooth out? How many one will keep this tooth in? How many undecided voters? So this case is palatogingival growth all the way to the apex. So I decided there's only one option I'll try with this case. To do root canals, minimize inflammation, knock this tooth out, take the groove out, put growth factor, replant it again. That's the only option I had. I told the patient, I told her mom, I got a consent form. And we did it. I did the root canals. 8 weeks later, I extract the tooth, I bore out the groove, I put in again. This is 8 months later. This is 6 years later. There's no ankylosing, nothing there. So it is very important to translate the research from basic science to a human being. So you can see here to here. The last points I want to make, for example, how to do research in terms of between bench sides to clinical. So we have done a lot of work on pulpal regenerations and endodontics in the past. And we were not able to be successful actually to reach a point to have a bedside experiment. So we did several monkeys and animal studies in early 2000. We were able actually to prove that we can able to go next level. So we published about a few papers in the Journal of Endodontics looking at the effect of growth factor on the pulp. Then from that point, we have consensus. We did the first human study with Dr. Al-Fawzan from National Guards. So this is hopefully be published soon. We submitted the manuscripts in December after 5 years review of the histology and the micro-CT. So what we did, if you go back to my papers in the Journal of Endodontics to take the backgrounds of the monkey studies, you will have better understanding where we're at here. So what we did, this is part of the monkey studies here. What we did, we put the growth factor plus MTA. You could see a very nice PDL, good amount of dentin formed here. Why I'm doing a rotation, complete 360 degree, show the apices, there's no infection here, no bone destruction here in the periapical tissue. And this is the same thing here. It just mimics the same radiographs here. You can see the amount of dentin here has been formed. And this is part of the paper published in Journal of Endodontics to show you in the monkeys we were able to produce with the growth factor a good amount of dentins. And this is part of the paper as well. So anyway, I and Dr. Fawzan came up with the protocol has been approved by the IRB and National Guard. And what we did, we took patients referred for orthodontics extraction. So we consented them, we explained to them. So we did open the pulp tissue, obtain hemostasis there, put cotton pellets, send the patient to drink coffee to induce inflammation, then bring them back after 2 hours, then use the treatment methodology, either MTA or MTA plus growth factor or calcium hydroxide. I'll just show you the clinical video here, what we did exactly. This is a patient. We did clean after they came back after drinking coffee and sweets, and we used either MTA. This one have chloride, cleaning the pulp horn, putting MTA, for example here, and one group putting in calcium hydroxide. So we had 49 patients. They were having planned orthodontic extraction premolars. You can see here, we're going to place now growth factor here afterwards. It's actually calcium hydroxide. The third case will be a growth factor plus MTA. Now we're going to dry it. See, now we're going to place the gel. You can see a protein-like material going to be placed. This is a platelet-derived growth factor here. Then we place MTA on top of it. So this is MTA alone. If you look at it, this is one of the teeth we took. If you look at this is MTA alone, how much dentin produced. If you look in the clinic, you see only mesodistally line of dentin, but you never see buccolingually. There's voids there. So if we take, this is amalgam here, the bluish, the grayish, this is part of MTA. This is the dentin, enamel, this is the dentin here. We're going to evaluate, assess how the newly formed dentin, which is the orange line, that's a newly formed dentin after the application of MTA alone. So we're going to remove them one by one now. Remove this. So if you look at mesodistally, you're going to see a very nice line of dentin. However, buccolingually, this is big voids here, buccolingually here. So the bacteria can penetrate actually to the pulp tissue here. And this is consistent in all the cases we have for MTA alone. So if you look at from, let's say we go from the apices back into the occlusal view. So you can see here, there's gaps here, gaps here, gaps here, gaps here. Now compare this to if you have hybrid approach and growth factor plus MTA. So this is the enamel, this is the dentin here, the yellowish. So we're going to now dissolve them, look at the dentin. This is the newly formed dentin, this is the MTA. Now look at how consistent mesodistally, buccolingually, the newly formed dentin. So if we go occlusally and assess him, this is the last slide. I got 3 minutes. So if you look at here, there's no gut at all. And if you go down from the apex going back to the occlusal, you see complete seal of the pulp tissue. You could see here a huge amount of dentins consistent. So the points here, I think pragmatism and doing research, it's to do something that's of a national interest and to your community is very important. If we do something not related to our community, not related to our national interest, it will be a waste of efforts and energy combined. I think it's very important to have coordinations between research centers and the country here. Thank you.
Thank you, Prof. Khalid. Actually, that wasn't enough time for you to go for everything that we wish. Maybe we have to dedicate one full day to elaborate more about the potential of research and methodology. I think half an hour is too short for you to present all what you have. In general, I think we are tight on time. Maybe we can accommodate one question if you have. So it seems that
كلام سهل الموضوع خلاص.
It's very thing. Actually, we witnessed collaboration before, and that was an initial step. It's an important step when you offer the micro CT for graduate. And personally, I took advantage from the micro CT lab that in my PhD research project in Gothenburg, and I wish that really the university, not at individual level, they start to collaborate with each other to open venues for students and graduate residents to collaborate.
I can't agree more. I think it is fundamentally important for all students. They are in the land of Saudi Arabia here. They benefit from this research facility, and they must, I think, they must have access. One of the beauty of when we had the GFBR at King Saud University, I think every postgraduate students abroad had a free and unlimited access to the micro-CT. And the beauty of this actually consolidated a lot of efforts between different faculty. I remember having faculties from King Abdulaziz providing 3-4 students. I remember about 5-6 people in King Saud from National Guard. And this is projects that can address what we need here in our community.
Yeah. On behalf of the organizing committee and conference, I would like to present certificate of
السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير جميعا. We'll move on with our second speaker, Dr. Nasser Al-Asiri. Dr. Nasser Al-Asiri is a consultant and head of the Oral Maxillofacial Surgery Department at Prince Sultan Military Medical City. He got his BDS degree from King Saud University in 2004, and then he got his diploma of membership in oral surgery at the Royal College of Surgeons from Glasgow in 2006, and also he got his Saudi board training in oral maxillofacial surgery in Saudi Arabia in 2011, and finally he achieved his clinical fellowship in orthodontic and cleft surgery. Today he's going to talk to us about the current concepts in cleft management. Please welcome Dr. Asiri.
السلام عليكم. First of all, I would like to thank the organizing committee for their kind invitation. It's a pleasure for me to present in such great meeting in front of my mentors, my colleague, my resident and student. Today my talk will be about the current concept of cleft lip and palate management. I would start with this picture. Actually, this is a real ultrasound for a pregnant patient at the second trimester when she went for the regular follow-up. And her physician took a regular follow-up for the ultrasound, and they found this small fissure. And she asked him about that, and he said this is probably cleft lip and palate. She waited for another 3 months, and she delivered with this baby. And you can imagine what type of treatment she needs along her life. This baby needs to go for cleft lip and palate, as you can see here, at the age of 4 months. And then the cleft palate has to be closed at the age of 1 year or 1 year and a half. And then if the patient has any speech problem and he needs any pharyngeal flap, she will do it for the age of 3 or 4 years. And definitely all cleft patients will go for orthodontic treatment and possibly alveolar bone graft. And then many patients, around 60%, they will need conventional orthodontic treatment, Lefort 1 advancement for the maxilla, and a later stage at the 70% of cleft patients, they will need rhinoplasty. The reason why I start with this, just to show you our experience in one of the biggest hospitals in the kingdom. I am the head of maxillofacial surgery department in Prince Sultan Military Medical City, where we see a lot of cleft patients on a daily basis. I'm very lucky to work in harmony with a very nice team with different specialty, orthodontic, pedodontic, genetic, speech, ENT, social, and my great colleague, Dr. Khalid Al-Saad, Dr. Imtinan Al-Majid, Dr. Mohammed Shamrani, and Dr. Udad Al-Adib, and our resident and specialist. We did in the past 10 years more than 1,000 cleft lip and palate procedure. We meet in this combined cleft clinic twice weekly, and we are involved in some research project, and we published some data from our center. We should not forget our mentor and the one who guided us and taught us about cleft lip and palate, and he is the one. He created the cleft combined team in Prince Sultan Military City, Dr. Abdullah Al-Aitel. I feel very proud to see him today attending my lecture. And the reason why we have this combined team is simply everyone has his own or her own rule in management of cleft lip and palate. Genetic counseling is very important for any cleft lip and palate, simply because 30 to 50% of the cleft patient, they born with a certain syndrome. More than 300 syndrome associated with cleft lip and palate. In some cases, when we see abnormality in their body or their face, we do immediately chromosomal analysis, and we consult our colleague from genetic department. The etiology, as everyone knows, it has no clear etiology, this cleft lip and palate, but it's been agreed that 50% could be genetic, 50% environmental, and the risk of this cleft lip and palate will increase double with the age. After the age of 30, the pregnant will have the risk of double than those is below 30, and treble above 40. And unfortunately, until now, there is no proven pathways or mechanism that is responsible for cleft lip and palate. There is a lot of research going all around the world, and hopefully one day we will reach to this pathway and we could prevent this to happen to our patient. Pedodontist is also very important in our team. As you all know, in cleft lip and palate, we see a lot of dental anomalies, including supernumerary, missing teeth, crowding. They are highly involved with us. They do good prevention. As we all know, cleft patients, they are prone to have teeth caries, so they see them from the first year up to the mixed dentition, and then they will be also followed by other colleagues. In some center also, they are highly involved in providing obturator for the cleft palate patient, where it will help the patient to have a good feeding without nasal regurg. Orthodontist, I cannot imagine any cleft combined clinic without this specialty. Their presence in cleft management is crucial. They are monitoring the growth of this patient, and sometimes they modify the growth of patient. And we can decide with them whether this patient will go for alveolar bone graft before the expansion of the maxilla or after. It's very important in cleft management to decide from early stage whether this patient will go for orthognathic surgery or distraction osteogenesis, or he will go with non-surgical treatment. This is one of the classic cases that we see in our clinic. So patient will be seen by the orthodontist. They will start with the quadrihelix expansion. As you can see, there is a cleft lip and palate here where it's, you can see the segmented collapses. There is some crowding. So they do the maximum expansion, and then they follow the patient along the ears, and then they remove the primary teeth in the area of the cleft, and then patient will be referred to maxillofacial surgeon for alveolar bone graft. After the grafting, they will bond the canine, and then they will take it to the occlusal plane. You can see very nice arch formed by the orthodontist. At a later stage, we just put something temporary in the area of the lateral incisor or the canine if it's missing, and then we decide after the complete of the growth whether this patient can go for prosthetic treatment or he will need implant treatment. And this is the patient pre and post. Prosthodontist is also very important to be in the team. They do more than prosthetic treatment, I mean in the dental region. They really can help with the cases with the big fistula where we cannot operate anymore, whether the area is compromised by multiple surgery or the patient refused surgery. Sometimes it's a good option just to provide them with an obturator that can cover the area and improve the speech. They are highly involved in prosthetic rehabilitation after orthognathic surgery or after orthodontic treatment. They are also involved in speech therapy. Sometimes the speech therapist will ask for a certain procedure where we cannot achieve it by soft tissue. So they provide something we call it palatal lift appliance. It will really help the patient to have a better velopharyngeal competence. And this is what I mean by the velopharyngeal competence. This is the normal patient in resting position while he is not talking. And here, when the patient is talking, you can see complete seal of the velopharyngeal area simply because the tensor palatine, levator palatine is tensed and can close and reach to the posterior pharyngeal wall. While in cleft patients, sometimes it will be impaired simply because the muscle is affected. So such patient will be seen by the speech therapist. They will try to do some training. They will try to improvement. In some cases, they will just refer it to us and do some surgical procedure. We will explain it in the coming few slides. ENT is also very crucial. In our team, they are with us. They assist any patient with cleft palate, and then they evaluate the need for a ventilation tube. And this ventilation tube is very important to decrease the discharge from the middle ear. When we have a cleft palate patient, the Eustachian tube, which is connected from the palate to the middle ear, is impaired because the muscle is not working. So they put something we call it a grommet tube or ventilation tube that is resorbable. They join us during lip or palate repair. And of course, it's very important to do a regular follow-up for their audiology or ear function. So what's the role of oral maxillofacial surgeon? I usually have this big argument with my colleague in plastic, ENT, pediatric surgeon. My opinion that I think the surgical part of cleft lip and palate should be done only by oral maxillofacial surgery, simply because he is the one who is really oriented in this area. We deal with the maxilla, mandible, palate in a daily practice, and I think we should do this part of discipline in most of the hospitals of the kingdom. Luckily, in Prince Sultan Military Medical City, we do the full scope of cleft lip and palate, starting from lip repair until the orthognathic surgery. It's a nightmare sometimes when you have a wide cleft lip. You need to think the whole night what design will fit to this lip. And I usually just take photo for the patient, print it, and I try to mark and design my flap. But unfortunately, sometimes you go next day and you found it very difficult. When do you operate lip? When do you close the lip? We do it at the age of 4 months when the patient can tolerate the general anesthesia, when the patient at the weight of 10 pounds and the hemoglobin above 10. We do different techniques. We've been trained with Dr. Abdullah Little to do different techniques, especially Miller technique, Fisher technique. Nowadays, I think it's accepted in many centers that you can do cleft lip repair as a day case surgery. Patient come in the morning, do the surgery in 1 hour, stay 3 to 4 hours in the recovery, and then they can go. In my practice, I don't really give antibiotic, and this is something already established also in the literature. I just give 1 shot during the general anesthesia, and there is no antibiotic post-operatively. So what do we do exactly? And intraoperatively, it's very important to spend time just to try to mark the area of the incision. Again, it's multiple incision you can or technique you can use. Here we are doing Fisher technique, where we can match the area of the normal lip to the other area. It's very important to dissect the muscle and make sure you have a good closure, passive closure without tension. That will help functioning better for the patient and also for the formation of the scar. It's very important also to check the symmetry of the nose and provide the patient with the best functional and cosmetic result. Luckily, sometimes we get a nice result, but it's not always the case. Sometimes we have cases where we have small scars, we have asymmetry in the nose, we have whistling deformity. We try our best to delay the secondary intervention until the complete of the growth, unless it's something very obvious and the parents are worried about it. Sometimes we face difficult cases where there is a bilateral cleft lip and palate, where it's very difficult intraoperatively to approximate the tissues and get the maximum repair. So such cases, we have the choice to do what we call nasolabial molding. It's a small device, can be constructed in the lab, applied to the patient, and gradually it will restrict or it will retract the maxilla or pre-labium and pre-maxilla, so it will allow us to close the lip nicely without tension. Lip adhesion is another technique. You can do it in very severe cases. You just take patient to OR and just approximate the muscle without definitive lip repair. Nowadays, we are doing this type of nasal remodeling. We put nasal retainer immediately post-operatively. We keep it 2 months, just to allow better remodeling for the nasal cartilage after dissection. We don't really do a lot of nasolabial molding simply because we have a high flow of cleft patients, and most of them from outside Riyadh. It will be very difficult for them to provide it and review them in a weekly basis. But there's a certain cases where it's very wide and we don't have other options, so we do it. Palatal repair is another important part of cleft surgery. The cleft palate, we do it after the age of 1 year simply because it's the time for the patient to speech. We do the lip repair, palate repair mainly for the speech, not for the nasal regurg. Again, it's different techniques. Nowadays, it's also accepted that you can keep the patient 1 day only just to make sure the airway is patent. Again, we give just 2 doses of antibiotic with no post-operative antibiotic, and it's proved it's safe with a very low incidence of infection. Again, the basic principle of cleft palate surgery is to do 2 lateral incision and 2 medial incision, dissect nasal layer and palatal layer. It's very important to achieve good muscle repair, simply, especially lip repair, especially tensor palatine, elevator palatine, and then to close without tension. If there is tension, you have to change or modify your technique and take from the vomer flap, which is the lower part of the. And again, this is what we do in cleft. Basically, we dissect medially and laterally, and then we reflect full mucoperiosteal flap laterally, and we try our best not to have single tear. The pterygopalatine, greater palatine there, we have to keep it patent, because if we compromise it, the whole flap will be compromised and we ended up with ischemia. Here we are taking vomer flap simply because it's a wide cleft palate. We cannot achieve nasal closure without having this. And then again, it's very important to have a complete muscle closure, especially tensor palatine and levator palatine. Palatal fistula is something also we may expect it in some cases, especially in very wide cleft palate. In the literature, it's 10 to 15%. We have in our hospital a lower rate, around 8 to 9 in our records. The significant point of fistula is the speech. If the patient has a fistula, it will affect mainly his speech. So we consult again our colleague from speech therapy. They do endoscopy, they do some tests, and then they tell us whether this fistula is interfering with the speech. If it's interfering, we have to go and close it. Most of the time we do local flaps, either buccal advancement flap, palatal rotational flap, any other, but sometimes we face a very large fistula where you need to think and take something far, like the tongue. Tongue flap is a very reliable flap. It's a very vascular. The success rate most of the time is very high. There is no significant second side morbidity. It's just to take posterior based flap and then raise it to the palate and suture it for 2 weeks and then release it, and you can see the nice vascularization, and this is 1 year after repair. Speech again is very important after any palatal repair. Sometime our colleague from speech therapy will ask us to do any surgical intervention, either to augment the posterior pharyngeal area with fat, with any type of material, but the gold standard is to take from this tissue and connect it to the soft palate. And this is the common procedure for the velopharyngeal incompetency repair. Here is a case where I took from the posterior pharyngeal wall superior based flap, and then I dissect completely up to the prevertebral fascia, and then I connect it to the soft palate. You can see here is a complete closure. When you do this, most of the time you are decreasing the hypernasality. The air that escapes to the nose will be less, so the patient will improve. And again, our colleague from speech therapy, they do good assessment for those patients. You can see this is pre-op, where the patient is not having any contact during speech. Here's the soft palate, here's the posterior pharynx. And here you can see the flap that we created. That will decrease the air escape. It's not complete closure, but at least the central part will be closed. Alveolar bone graft is also a very important step for cleft lip and palate. We do it before the canine eruption at the age of 8 years. It allows the orthodontist to form the arch. It facilitates the orthodontic treatment, and sometimes it's good to do it along with the fistula closure. What do? We do the classic way of the incision, sulcular incision, extended to the cleft area. We make sure here to create two flaps, nasal flap and palatal flap. If we create one flap only, we will end up with the graft going through the nose. We had a good data from the last 10 years that we are using allograft, which is initiated by Dr. Abdul Aitel 2005. Nowadays, we are using this as a routine. By doing the allograft, you are, of course, avoiding the second side morbidity of the iliac bone or tibia or other source of the autogenous bone. You can discharge the patient immediately and avoid some complication you may have it with the other graft. Nowadays, one of the current advancement in alveolar bone grafted, you can take CT scan, you can measure the amount of defect that you have, and then you can just print it with the 3D printer and have a special template that will let you know exactly how much of bone you need. So going like what we are doing in the past, just opening many ampules of allograft or taking a lot of iliac bone graft, and at the end of the surgery, if there is any rest of the bone, we'll just throw it, is not applied anymore with this template. Orthognathic surgery in cleft patient is also a final stage from maxillofacial department. We face mainly three major problems with those patients. The scar tissues in the palate or the lip is something very difficult to deal with intraoperatively, because after any intervention, either from the lip repair or palatal repair, this will cause scarring of the tissues that will restrict the growth of the maxilla forward, and will be complicating the surgery. Fistula also, sometimes we could have it intraoperatively, simply because we are opening everything again, we are advancing the maxilla, we are stretching the palate, and we end up with a nice AB position, but with a fistula. Other major issue is the velopharyngeal incompetency. When we advance the maxilla big amount, like what we do mainly in the cleft patient, we ended up also by taking the soft palate forward. So patient will have velopharyngeal incompetence. So it's very difficult decision how much you go forward, whether you can go for Leafort or no. Luckily in Prince Sultan Military Medical City, we have 3D software that we can apply it in any case, either orthognathic for cleft patient. Last week we did a very interesting case for Romberg syndrome. Using this technology, we designed a special onlay for the forehead atrophic bone and the fourth zygoma and zygomatic arch and maxilla, and then we implanted there. So 3D facial planning is very important for assessment of our cases. We could have a better diagnosis and evaluation of the final outcome. Here's the cases when it's not managed probably from the beginning by a dental specialty. You can see here acceptable lip repair, but you can see the whole profile is diminished, the nose is deformed, and when we took CT scan, we can see there is no good bone grafting, there is no orthodontic alignment. So the role again of dental specialty is very, very important in cleft management. Here's another patient is going for orthognathic surgery. Next week I spend many hours just to plan this case. Why? Because in cleft patient you want to do only single jaw, because the problem only in the maxilla. But when I did it in virtual planning, I found that I needed to move the maxilla around 13 millimeter, which is very, very much, which will cause a lot of problem, and the patient may end up with relapse. So I decided with this nice software to go slightly with the mandible around 3 millimeter and slight advancement of the chin that will give us a better profile, a predictable result, and less complication. Destruction or osteogenesis is also another type of management. You do it for severely retruded maxilla. You can do it extraorally, intraorally. Along with our colleague orthodontist, we follow patient on a regular basis and try to utilize the healing stage and get better occlusion. I could conclude from my presentation that cleft lip and palate is a very complex, complicated type of treatment for everyone. But I think it's not only one man show. It's not the surgeon, it's not the orthodontic, it's everyone. And unfortunately, in many hospitals in the kingdom, there is no proper, well-dedicated cleft lip and palate team. And unfortunately, some surgeons, they like just to do their part and just refer it to the other department. I think to improve our management for cleft patient, it's crucial to have all specialty involved in such treatment. Before I end up, I just want to announce for our two courses, one Saudi or maxillofacial update review course. It will be in January, along with 15 very expert senior and newly generated, some of the new generation maxillofacial surgeon. whom they will cover all topics of maxillofacial surgery. We did it last year. We had a very good, successful meeting, and we will do it this January. Another meeting, I would like to thank Riyadh Al-Ilm University for giving me the opportunity to do 10 courses of basic surgical training. We had a very nice evaluation from the previous participant. I would like to invite anyone interested to join us next week. At the end, I would like to thank you all for being here.
Thank you, Dr. Nasser, for this great, informative presentation, mashallah, with a multitask or multi-speciality approach. Maybe we have a chance for one or two questions, please. Anyone or any comments? That's fine. If not, there's one. Sorry, go ahead.
Thank you, Dr. Nasser. It's a very nice presentation. As I have a question about how much we can move the maxilla in limitation. So the maxilla with a cleft palate and compared to a maxilla without cleft palate, what's our limitation in advancement?
I'm sorry, I cannot hear you well.
In advancement of maxilla,
Okay.
What's our limitation in millimeters and compare with the cleft palate and without cleft palate?
Okay, nice question. The question, how many millimeters I can go forward with a maxilla and cleft lip and palate patient in orthodontic surgery. Actually, the number is sometimes misleading, simply because this cleft can be unilateral, can be bilateral. Some cases they are grafted, some they are not. But there is acceptable, maybe a statement that up to 8-10 millimeter will be very difficult to achieve more advancement. And if you go above 10, you are inviting for relapse and also sometimes necrosis of the whole maxilla, because you are stretching, dissecting the whole soft palate just to go forward.
Okay. Any more? That's it. Thank you, Nasser. Dr. Nasser, I would like to give you this certificate of appreciation for the presentation.
Yes.
Our next speaker, Dr. Fawaz Al-Qahtani. Dr. Fawaz, he's an associate professor and consultant in prosthodontics at College of Dentistry and Prince Sultan bin Abdulaziz University. Dr. Al-Qahtani is the director of implant diploma program at Dental College of Riyadh Al-Ilm University. He graduated with a master's degree of prosthodontics from University of New Jersey, and he has a fellowship in surgical implant from Loma Linda University. He's a diplomate of the American Board of Prosthodontics. Welcome, please, Dr. Fawaz Al-Qahtani.
السلام عليكم ورحمة الله. سيد الله مساكم كله خير. Inshallah, very well informative day for everybody. Thank you, our chairman, for the nice introduction. I would like to thank Riyadh Al-Ilm University and the scientific committee for this meeting, for their invitation. It is really a pleasure and honor to be with you today to just share with you some of my clinical experience in dental implantology. As you know, nowadays the implant is considered as the fairest option to replace the missing tooth. Excuse me, can I have the pointer, please? Hello? Pointer? Okay. As you know, nowadays, with all improvement in implant surface technology and implant surface geometry, the success rate of dental implant is getting higher. Some of the studies with almost 13 years follow-up, you will find the implant success rate is exceeding 95%. And some of the publication with 7 to 10 years follow-up, you will find the implant success rate is more than 99%, which seems very promising. But unfortunately, despite the high success rate of dental implantology, you might face some of the patients coming to your private clinic with unsuccessful, or we call it aesthetic failure. And the problem came mainly from improper planning and improper placement of the implant. We don't face any problem nowadays with the osseointegration of dental implant. Implant now can osseointegrate very well, even with the patient they are medically compromised and they have problem with the bone remodeling. But unfortunately enough, the most of the problem that we are facing is mainly aesthetic failure. And the treatment in most of those cases due to improper implant placement is mainly very aggressive and destructive, and most of the time you will end up with removing the implant. Removing the implant, you need to regenerate the site until you reach to the proper development of the site where you can place your implant in the proper position, which can be restorative driven. Today my presentation, I know it is Saturday afternoon, I will try to go through some of the interesting clinical cases just to show you how you're going to place your implant in the proper position where it's going to be restorative driven and biological stable. Either conventional placement with immediate loading or going for immediate placement without any loading. This is mainly in the posterior, and with immediate replacement. What I'm going to just explore to you is how you can place your implant, what we call it 4D planning, where you will place the implant in vertical placement of the implant, buccolingual placement, where you're going to place it in regard to the adjacent vital structure, as well as the angulation for the final prosthesis. If you look to the vertical placement of any implant, and if you go through the textbook, most of the textbook and dental literature in the past, they use the cemento enamel junction as a guide to place the implant. But unfortunately, this mark, it is not reliable anymore, and it's not reliable. We cannot use it. Mainly as restorative dentists or prosthodontists, we place our implant mainly 3 to 4 millimeter below the deepest part of the soft tissue. In this scenario, we will be able to customize the soft tissue. We'll be able to provide the patient with a restorative option that's going to be very successful, and the patient will be happy with the final aesthetic outcome. Either you open the flap, or in flapless technique, if you have a single tooth where you're going to extract the tooth and place the implant must be placed 3 to 4 millimeter below the soft tissue. And if you look to the second case, where we're going to open the flap, we're going to cut some part from the bone to be able to place the implant in a restorative driven position. We go with wax hub, and then from the wax hub we make a suck down template. When you release the flap, you lose your guidance. You don't know where is the soft tissue going to be, but mainly using the surgical template, as you see here, you will know where you're going to cut the bone and where you're going to place your implant. Then you will do the alveoplasty, and you're going to place the implant, as I mentioned before, 3 to 4 millimeter below the free gingival margin. Some people, they will feel humble. They will try to place the implant deep, and to make their restorative colleague happy, they will say, okay, we're going to place it deeper to be able to have a good emergency profile, and then the restorative dentist will be happy. He can play with the tissue more. But unfortunately, if you place your implant more deeper with a lot of publication, it shows you're going to have more crystal bone loss. And then 0.5 to 1 millimeter error in aesthetic zone, usually it will lead to a destructive treatment. That means the implant must be placed in the ideal position. If you place your implant more coronal, it will lead to unfavorable aesthetic. We receive some of the patient, the implant has been placed, unfortunately, at the crest of the bone, but there is no enough soft tissue height, and it is in the aesthetic zone. We cannot make the lateral look like the other lateral, or the central look like the contralateral central. We end up most of the time with overlay the crown, what we call it, is a modified lab. Unfortunately, this area, which is the over contour, will lead to black and bacteria. At the end, it will lead to bone loss. Okay, that means vertical placement of the implant is very critical to avoid any aesthetic failure. If you look to the buccolingual position, and this is a big dilemma in the anterior aesthetic area where you're going to place your implant in the proper position in regard to the buccal bone thickness. We need to have a sufficient buccal bone thickness to be able to have a stable free gingival margin and also less marginal bone loss. The recommended thickness of the buccal bone is mainly around 2 millimeter. Some cases we go around 1.8, but ideally, as much as you can keep it for buccal bone thickness, you will have a biological stability. As you see here, this implant place, and you can see how we can able to maintain the buccal bone in the proper position, even above the abutment implant connection. Let's go through this case, and this is most of the cases that I face in my private practice. When you have a patient that you're going to extract the tooth and you're going to do immediate implant placement in the aesthetic zone, as you see here, this canine will go for extraction. Unfortunately, most of the maxillary anterior teeth is placed buccally. And the only way you can diagnose that is through going through the sagittal section of the CBCT. If you see here, if I'm going to place my implant, and this is most of the restorative or implantologists, they go through this placement to place the implant in the socket after extraction. This is what you will end up with. Implant has been placed in the same socket. You will end up with fenestration in the apical part from the implant, and this bone will be lost with time. That means immediate implant placement is very critical, and it must go through proper diagnosis. Since if you're going to follow the same socket, you're going to place your implant outside the bone, and this is what you're going to end up with. There is no such a treatment except removing the implant, GBR, and then later on you're going to place the implant. And proper planning from the beginning will lead to destructive failure at the end. The ideal placement of the implant, it must go a little bit palatally to maintain more bone in the buccal, to resist more recession in the future. And if you reach to the danger zone, usually will lead to a bone loss, and at the end it will lead to aesthetic failure. The ideal treatment for this patient, as you see, this is the socket after extraction. I shift the osteotomy more palatal. I want to engage more of the palatal bone, as you see here, by shifting the implant a little bit palatally, and then the implant will be placed while I can have more buccal bone to support the tissue. As you see here, we have around 3.5 millimeter, and you can see in the CBCT we have a good thickness from the bone. As you see, even the bone is above the implant abutment connection. Some of the implantologists, and mainly when you have a good bone width, they will try to place the implant more palatal to have the tissue more stable. Unfortunately, placing the implant in the palatal position will lead to over contour, and usually it will lead to plaque and food accumulation, and this will lead to aesthetic failure. That means 0.5 to 1 millimeter error of implant placement in aesthetic zone usually will lead to a successful restoration. This is, I think it is very clear to everybody, implant must have at least 1.5 from adjacent teeth and also 3 millimeter from adjacent implant. And if you're going to place the implant close to each other, this is what you're going to end up with. And this is, unfortunately, you will see it from the dentist. They don't have any planning. They don't use a surgical guide to place their implant. You will have implant placed close to each other. You cannot have interdental papilla. You will not be able to maintain the bone between two adjacent implants. The treatment in this case is mainly you're going to remove some of the implant, or you're going to bury those implants and just restore with 2 or 3 implants, okay? Regarding the angulation or the position from prosthetic point of view, this is what we like to have, the implant placed in the cingulum area or more palatally to have screw retain restoration. Unfortunately, sometimes the angulation of the premaxilla area prevent us from placing the implant more palatally, okay? In this scenario, usually we angulate the implant, but the implant must be placed in an area that's going to be a restorative driven, a little bit more palatally, and then you will have the final prosthetic outcome This is a zirconia abutment. It's going to mimic the adjacent tooth. This is just to keep it in your mind. This is the 4D planning for any implant will be placed in aesthetic zone, either from central to the premolar area. We'll go through some of the cases just to show you how we will place the implant in a restorative driven position, where I'm going to restore this implant nicely. I will not suffer with the restoration or the final restoration or the aesthetic outcome. Nowadays, with the CBCT, with the visual planning, as Dr. Nasser mentioned, we have a lot of details. We can provide to our patient the best treatment outcome. Nowadays, we are not practicing dentistry like 15 or 20 years ago, where we don't have CBCT, we don't have visual planning. We cannot diagnose the patient before we go to the surgical site. If you look to this patient, 19 years old, female, presenting after ortho, congenital missing lateral incisor. This is one of the difficult cases that you will go through. This patient, she doesn't have another option rather than go with dental implant. Different option, you might go with Maryland, but it's gonna debond every time. Or you will go with cantilever. It's not recommended in the aesthetic zone. And then the only treatment for this patient is to go through dental implant. If you look here to the CBCT, this is what I mentioned, the premaxilla, we have an angulation. You're gonna follow this angulation to place your implant in the ideal position. If you try to have a screw retain restoration, what you will end up with, the tip of the implant will be outside the bone. That's mean when you place the implant, you're gonna angulate it within the bony envelope, but at the end, we'll go for custom abutment. We don't depend a lot of time for BA or panorama or the OBG. We usually go with the CBCT. CBCT is more accurate and the amount of distortion is little. Besides, it provides a huge amount of information. It can give you 3D image where you can see the bone in buccolingual direction. With two-dimensional X-ray, you will not have all of this information. If you look to this patient, this is an implant after its placed. We went ahead, as you see, we have the CBCT. You're going to make sure the implant is placed within the bony envelope. And then we went to provide or adjust our temporary abutment. And this is how's the provisional look after 6 months. We usually take a lot of time after 4 months to modify, to customize the soft tissue to be able to provide the patient with a nice restorative contour, and then the lateral will look similar to the contralateral missing tooth. This is when we reach to the final prosthesis. As you see here, we will go for cement retain restoration because the angulation of bone and the angulation of the implant. This is what we call it positioning jig. We use it with the cement retain abutment just to make sure we are placing the abutment in the proper position. This is how it's look at the time of the delivery. It is a cement retain restoration. You can see we didn't jeopardize the adjacent teeth. We are providing the patient with an excellent aesthetic outcome where it's going to be biological stable through the rest of the life of this patient. This is the X-ray at the time of the delivery. We usually take the X-ray to verify the seating of the abutment and also to make sure there is no remnant cement. This is another case. Patient present with tooth number 14, badly broken down. We decide we'll go for extraction, immediate placement and immediate loading. This is after we extract the tooth, and now we'll go for implant placement. As you see, we try to place our implant in the center of the socket to go for screw retain restoration. This is after we place the implant, we place a cover screw just to augment the site. And then we went ahead with the customization of the titanium abutment. Now we will remove the abutment and the temporary crown. We attach it to the implant analog or implant replica to customize the soft tissue contour. You can see it at the same time after we did the cementation. And you can see this is our restoration immediately. The patient leave our clinic with a tooth. This is what we call it, tooth in a day. Okay? And now you can see the soft tissue, how we can play with the temporary crown to push the papilla to both sides until we are ending with the final aesthetic outcome. You can see how we start and how we end up with. I think now the soft tissue is stable to go for the final restoration. This is the CBCT after. You can see we are placing the implant in the ideal position. We are maintaining 2 millimeters of bone buccally. This implant will be biologically stable for a long period of time. Without CBCT, we will not be able to know where the implant is from buccolingual position. And most of the failure that we are seeing is regarding the selection of the implant. Implant, if you place it very wide, you will jeopardize the buccal bone, and then you will end up with unstable gingival tissue. If you look here to another patient, this is a professor at Prince Nora University. Female patient, she got an RTA. You can see some of the veneers chipped, and then she has a fracture, the premolar. She wants to go with an immediate smile. She wants to restore the missing tooth with the implant. She doesn't want to touch the adjacent teeth. As you see, this is how it's looking in the X-ray. This tooth needs to be extracted. I went ahead, I took an alginate impression. I sent it to the lab to do diagnostic wax-up and to fabricate a shell, or what we call it, a temporary restoration, temporary crown. And intraorally, I will do a direct or immediate loading. This is after I did the extraction. We placed the implant in the center where we maintain a good amount of buccal bone, and we can have a screw retain restoration. This is immediately after I placed the implant. This is the temporary abutment after I shape it clinically. And then we spend time just to customize the temporary abutment. This is the temporary abutment with the final or temporary restoration attached to the implant analog or implant replica. You can see at the same time of the surgery, patient went ahead with an immediate restoration. As you see, there is a soft tissue defect. Usually, we try to play with the contour of the temporary restoration. And what we have we know there is a lot of article talking about critical and subcritical contour. And usually, if you make your restoration under contour, the soft tissue will immigrate, more occlusally. This is what you can see in the final restoration. After 5 months, we didn't do any soft tissue graft. We just play with the contour of the temporary restoration. If you are an excellent surgeon without excellent restorative dentist, you cannot achieve a proper aesthetic final restoration. You need to have a good collaboration, or if you are an implantologist, you can do both the surgical and the prosthetic part. This is the soft tissue contour. When you are taking the final impression, you can see how we are able to customize the soft tissue. We do all of this with just temporary restoration, just composite. You need to add, you need to remove until you reach to the proper position of the soft tissue. Nowadays, and a lot of dental schools, mainly in North America, they have a recommendation to take the CBCT before the surgery and CBCT immediately after the surgery, before you are doing the suturing. This patient has been transferred to me to do a prosthetic part. You can see Nobel implant has been placed. As you see, the implant position from this view, it's look excellent. Patient, she is complaining from the pain in the most apical part of this implant. If you see, this is during my impression. My patient came back to me. She is also complaining from the same area. I decided to go with a CBCT. If you are looking to panoramic view, it will not give you any clue. If you take periapical, it will not give you any clue about the implant position. Unfortunately, when I looked to different sections, I found the implant has been placed in an improper position. It is too much angulated palatally, while the apex of the implant is outside the bone. If he saw this case immediately at the implant placement, he will remove the implant, he will replace the implant in the proper position. That's why some people, they say, you are exposing your patient to a lot of radiation, but this is not right. Nowadays, CBCT, the new generation, has less amount of radiation exposure. Besides the fact, if this implant fails, how many times you need to do a CBCT after? You're going to take it before the implant, you remove the implant, you're going to take one after the GBR to place the implant again, and then you will take it after. That means you will do it almost 3 times. That means our recommendation, even here in implant diploma, in our dental school at Riyadh Dental School, we always go with a CBCT before and after. And if there is any issue, we can do an immediate correction rather than waiting 5 to 6 months and then removing the implant again. We just moved to the next case. This is a 3-unit FBD. This is one of our patients. They came to the clinic with those faulty bridge. After I removed the bridge, we found those teeth is non-restorable. It will go for extraction. We decide we'll go for immediate placement with immediate loading. We went with a Zimmer implant, and this is a temporary abutment. I use a suck-down template. It's very simple, easy procedure. All the dental clinic, they have the suck-down template. They can use it. I use it as a guide to place my implant, and also I use it to make the professional restoration. You can see the patient immediately. This is the temporary restoration within an hour after we remove the two natural teeth and placing two implant, and we load them, and this is the patient smile. We went ahead after customizing the soft tissue. We took a lot of time just to build the Bontic area, and then we use a zirconia Atlantis abutment, which is very aesthetic. In the anterior region of the mouth, it can tolerate high amount of tissue force, and this is the final all ceramic restoration. This is the patient smile after. Some people, and I have some discussion with some of my colleagues, they said, okay, immediate replacement or immediate loading, it will fail. And some of them, they are using a speculation. From our clinical experience, we found the conventional implant placement is more successful. But if you go back to evidence-based dentistry and you retrieve some of the dental literature, you compare immediate loading where you place the implant and you load it immediately with a conventional or delay loading where you load the implant after 2 months. All the literature, they are showing the high success rate for immediate replacement because you are stimulating the bone for regeneration, for remodeling, and then you will have more successful implant placement. This is one of the study by Romanos and Ternau. They retrieve all the data regarding immediate loading protocol where you load the implant immediately, and they found almost 95% success rate. And if you compare it with delay loading protocol, usually it is 91.6. There is, from statistic point of view, it is not significant, but for our patient, I think it's to provide a good help to deliver a fixed restoration at the time of the implant placement, rather than going for removable procedures and then you go for temporary, which will take 2 to 3 months. At the end, when we place our implant nowadays, we don't think a lot about osteo. Implant surface treatments is excellent, but what we are thinking is this implant, and it can stay for a long period of time. We are looking for biological stability of the implant. And to have a good biological stable implant in restorative position, you need to do a proper planning examination. You need to take aiding like CBCT to determine what is the size of the implant, how you're going to place this implant. Do you need to do a bone graft at the same time or not? And I would like to thank all of you to be with us today. I hope my lecture was going smoothly without, a lot of details. Then you will have more people sleeping in the back. But alhamdulillah, we are happy to have all of you. And thank you so much to be with us today.
Thank you, Dr. Fawaz, for the informative and excellent presentation. We will open the floor for discussion, and if we have any question. Dr. Abid.
Assalamu alaikum. Thank you very much, Dr. Fawaz, for an excellent presentation. And I'd like you to please elaborate a little bit on the restoration. Because there is lots of misconception when we talk about screw retained versus cemented. Are we talking about cement at the fixture abutment level, or are we talking about cement between the abutment and the crown? So please elaborate on that.
Okay, thanks so much for the nice and excellent question. It is merely when we decide to go for cement or screw retain restoration. In dental literature, there is no difference regarding marginal bone loss or or free gingival margin stability if we compare both of them. Regarding the complications, it merely there is no significant difference. But as prosthodontists or restorative dentists, we usually prefer to go for screw retain restoration because of the retrievability. If the patient came back with a screw loosening, it will be easy to retrieve, and then you will screw it down and that's it. But if it is cement retain and you have the abutment loose under the crown, then you are done. You need to section the crown, remove it, and then you will fabricate a new crown. And the way to control the excess cement, I think there is a lot of technique. It has been published in dental literature. One of them, some of them, they use retraction cord. Some of them, they use duplicate abutment to minimize the amount of cement, because cement will lead to peri-implant mucositis and later on will lead to peri-implantitis.
The reason why I brought this up is your presentation is about the anterior region, which is so crucial and critical for angulation of implants.
That's right.
And also for cemented restoration.
Absolutely.
Thank you very much.
Thank you, Doctor, for your question. Allah yafik.
Okay, on behalf of the organizing committee and the conference, we would like
هلا شكرا دكتور. We'll move on with our fourth speaker, Dr. Bandar Liami. Dr. Bandar Liami is currently an assistant professor of orthodontic and the chairman of the Department of Preventive Dentistry and Department of Maxillofacial Diagnostic Sciences at the Najran University, mainly the College of Dentistry. Dr. Bandar got his is board certified in orthodontics, and also he's a diplomate of the American Board of Orthodontics, and he got his master degree and certificate in orthodontics and dentofacial orthopedics, together with a fellowship in advanced orthodontics from the University of New York. And finally, he got his postdoctoral fellowship in craniofacial regeneration from Columbia University. Please extend our welcome and honor to have Dr. Bandar, who's going to talk about the biomechanical consideration in treating severe malocclusion. تفضل يا دكتور.
Which one is moving? Yeah, forward, backward. Okay. Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh. It's indeed my pleasure and honor to speak to all of you today. In this lecture, we will be talking about biomechanical considerations in treatment of severe malocclusion. Computer science and software engineers use different programming language to instruct their electronic or computing devices to perform a specific task, and has different example of the programming language they used. Whereas in orthodontics, we use biomechanics as our programming language to instruct our appliances to move the teeth and the bone in different directions with a specific force magnitude and moment. The great thing about electronic or computing devices that if they did any mistake during their programming step, they get an error notification few seconds later, allowing them to change the error they did and move to the second step. While in orthodontics, if you do any mistake when applying your mechanotherapy, for example, in this case, if you try to extrude this upper canine by using continuous arch wire, unfortunately, you will get your error notification when you see your result of your mistake. As you see here, instead of extruding the canine, you got posterior tipping of the teeth and proclination and anterior open bite. So, if we understand our biomechanics before starting treatment, it will allow us to do proper treatment planning, optimization of tooth movement, reducing the treatment duration, easy selection of the wires, bracket, and clinical devices, explanation and evaluation of treatment result, minimization of tissue destruction, research, evaluation, and development of new appliances. Now I will share with you treatment result of different malocclusion of my patient. The first case is 29 years old, female with a chief complaint, I want a nice smile. As you see here from her profile and cephalometric, she is retrognathic mandible, hypodivergent, retrocline and procline lower incisors. Her frontal view showing the facial type is brachyfacial, slight asymmetry, lips are over closed when bite down. Smile photos showing 90% of her upper incisor. The maxillary midline is on with the facial midline. The mandibular midline is 2 millimeters to the right, and she has, as you see from the smile, she has occlusal cant. Her cephalometric analysis showing retrognathic mandible, class 2, convex profile, as I mentioned, proclined lower incisor and retrocline upper, hypodivergent angle, obtuse nasolabial angle, and both lips are behind E-line. Her panoramic is showing multiple restoration, and most important for us here, she is missing lower right 5, lower right second premolar. From the intraoral frontal view, as we can see here, she is deep bite, impinging bite, and her overjet is 7 millimeter. The lateral or buccal view showing the molar and canine relation. On the right side, the canine relation is class 2. The molar relation, because of the missing of lower right second premolar, she is class 1. Left side, she is class 2, end on both canine and molar. Here, as you see the shape of the arch, and she has 2 millimeters of crowding both upper and lower. As we mentioned, you can see here from the cast analysis, you can see the 100% of impinging bite, as you see it here, and also the severe overjet she has. Also, it's important that she is excessive lower curve of speed, it's 4 millimeter. Moving to the problem list, we build our problem list with our objectives. So, as we mentioned, she is class 2 hypodivergent, convex profile, occlusal cant, retrocline upper incisor, procline lower, severe overjet and overbite, class 2 end on canine, and hair molar relationship is class 2 end on. Lower midline is shifted 2 millimeters to the left. Our objective is to correct the skeletal pattern, improve facial profile, correct the occlusal cant, improve the upper and lower incisor inclination, achieve proper overjet, overbite, and class 1 canine and molar relationship, correct also the midline. So the treatment plan was to do non-extraction surgical advancement of mandibular using BSSO. The challenge with this case is that how can we achieve our objective with only one jaw surgery to change the sagittal and the vertical dimension of this patient. So we had to carefully plan our biomechanics, preparing the case for the surgeon and make it easy for them to move the mandible forward and downward, changing sagittal and vertical dimensions. So we plan to maintain the excessive curve of speed before the surgery. So to maintain leveling the lower incisor together, the posterior by itself. So when the patient go for surgery and move the mandible forward and downward, we expect to have posterior open bite bilaterally. Then we will level it with elastic on both sides. This is how we start leveling and alignment. We start sectional mechanics by leveling the anterior by itself and leaving the posterior to level, so we will have two occlusal plane. When we got to rigid wire, we kept the lower anterior together. We did bend to maintain the excessive curve of SP. We asked the patient to move her jaw forward and downward, and that's what we expect after the surgery. Here is before surgery. This is the cephalometric before. As we procline the upper, try to maintain lower incisor proclination. This is 4 weeks after surgery, after we removed the, as you see here, the surgical splint. You see the bilateral open bite, and you start seeing the lower anterior after they move the mandible forward and downward. Then we give the patient vertical box elastic. We ask to wear all the time. And in 5 weeks, as you see, almost the open bite on the both sides almost closed. This is post-surgery, 4 weeks after the surgery. Here is the post-surgery panoramic. After that, we continue our orthodontic finishing and detail stage, and then we deboned the patient. As you see here, we achieved a great result by changing the sagittal and the vertical dimension of the patient, achieving class 1 canine and molar relation on the left side. We know that we cannot get it here because we're missing one premolar. This is the occlusal view. And here, as you can appreciate, the change on the face of the patient by moving the mandible forward and downward with one jaw surgery. Here you could appreciate the changes in number. This is initial, pre-surgical, and post-surgical. The sober on position will allow us to see the changes in the skeletal, dental, and the soft tissue. So here how she started, and this is after. This is before and after. You could appreciate the change in the smile. She was so happy and confident to smile. I was asking her here a hard time to ask her initially to take picture while she's smiling. She said, I'm not happy with my smile. Here, without even, she didn't even bite down. She's so happy about the result. Here is the initial and final of her profile. My second case is 17 years old. His chief complaint, I want to fix my front teeth. He was like pointing his upper right central, and his most concern is about this tooth. Here is his cephalometric and profile. He is convex, procline upper and lower incisor. His full dentition are present. Here is his intraoral frontal view. He has 0.5 to 1 millimeter of the midline shifted, 7 millimeter of overjet and overbite, 4 millimeter. His molar relation is class 2 and on both sides. So this case, he was asking for a specific treatment. He doesn't want any extraction of the upper. He wants to correct the upper central incisor, and he doesn't want any braces on the lower teeth. So it was a challenge for us to achieve a good result with this limitation. But we told him that we will try to do different biomechanics for you, and we will see the result. We told him about the limitation. So his problem list was class 2 skeletal, upper crowding, severe overjet, moderate overbite, class 2 on canine and molar, little shift in the midline, procline, upper and lower incisor. The plan is trying to improve the class 2 skeletal, eliminate crowding, achieve proper overjet and overbite, achieve class 1 molars and canine, correct the midline, and maintain the incisor inclination. So what was the plan? The plan was to do only one jaw, his upper teeth, because he thinks that his teeth is straight, the lower teeth, he doesn't want any braces. So the plan was to level and align the upper. When we reach a rigid wire 1925, we place 2 infrazygomatic mini screw and then apply night coil spring and try to distalize the whole dental arch. This is how he started. We bond and start leveling and alignment. Here we were trying to rotate this upper right second premolar. 8 months later, after placement of infrazygomatic mini screw with rigid wire 1925, here is he after 8 months of retraction using mini screw, infrazygomatic mini screw and night coil spring 150 gram on both sides for 8 months almost. We are getting class 1 canine and molar relationship. Here is his occlusal view. Then we continue the retraction for 2 more months, and then we try to finish and details. And here is he after debonding. We were able to achieve class 1 canine and molar relation. This is him before and after. Could appreciate his change in his smile. We got slightly improvement of his profile. This is how he started, and this is the final result of him. This is his final panoramic. Here is his cephalometric. My third case is 16 years old male with a chief complaint I cannot bite properly on the left side. So he has unilateral open bite, as you can see here. And the most important thing with this kind of cases, before starting any treatment, we need to make sure those teeth here are not ankylosed before bonding or using continuous arch wire, because we don't want any undesired movement of the other teeth. Here is his initial panoramic, cephalometric. So the plan was to design a mechanotherapy that would allow us to test the movement of the teeth first, and if the teeth will move, we already on the treatment. If not, then we stop what we are doing without any side effect or affecting the other teeth that in proper position. So the movement that we would like to see is extrusion of the upper left segment with some rotation to expand and to avoid the posterior crossbite. We placed mini screw in the lower arch and button in the upper left segment. We asked the patient to wear a rubber band. As you see, the force is coming away from the center of resistance of the teeth, which will allow us to move the teeth down and buccally without avoiding the posterior crossbite. This is the day of the placement of the mini screw in between the 5 and the molar. I placed the straight brackets together with the rectangular wire. Then I place a 3 button on this side. Then I ask the patient to wear the rubber band as much as he can to see if this segment not ankylosed, if it's ankylosed or not. 8 weeks later, he came with, as you see here, you can notice here, if I go back here, You can see the downward and buccal movement of this segment. We were so happy with this movement that we could continue our treatment without any concern about the ankylosed teeth. I placed some few micro-osteoperforation to accelerate the tooth movement. Then, after 6 months, after we bond all other remaining teeth, as you could appreciate the closing of the unilateral posterior open bite, we continue closing the spaces and finishing and details. Few months later, as you can see, we debonded him with closing or achieving our objectives. This is how he started. This is the final. This is his final panoramic. And this is the cephalometric. My last case here, he's 39 years old with a chief complaint, I don't like my teeth. This patient came to me after he went to different orthodontists, and most of them he was very sad because they told him the only option we have for you is surgical treatment. We cannot do any other option to eliminate the anterior crossbite and the problem that he has. He was asking me to do any other option than surgical. When he was to me, I looked at his smile. As you see here, you can see a good percent of the lower incisor shown, which will allow me to do some vertical changes and trying to auto-rotate the mandible and give me a less sagittal problem that I could correct with slightly proclining upper and retroclining lower. So what I did for him, I bond the upper arch, I place a posterior bite block, trying to open his occlusion. Then I try to change the proclining the upper, slightly retroclining lower incisor. When I got proper change the anterior crossbite, I remove the posterior bite block, and then I give him some vertical elastic, trying to extrude the teeth and change his vertical dimension, changing the sagittal dimension too. Here is a few months after the treatment. We were able to change slightly his profile and changing the anterior crossbite that he has. Now he is at this stage. We were planning to send him for implant evaluation, and he wants to do some veneers and some other restoration, changing his crowns. This is how he started, and this is him at this moment. So finally, if proper diagnostic records are obtained and orthodontic biomechanics are well planned, a great result can be achieved in patients with severe dental or skeletal discrepancies. Thank you so much for your attendance. Thank you so much for your time.
Thank you so much, Dr. Badr. Thank you for giving us some more time to hopefully discuss and throw in some questions. So please, if you have any. Dr. Hassan Abid.
Once again, thank you very much, Evan. I don't think this thing, is it?
It's working.
My question is about the last case. When you transform a class 3 patient into a class 1 from a non-restricted movement scheme to limited, I would say, anterior guidance or cuspid rise form of occlusal scheme. My question is about the stability, about such modality and such newer scheme of occlusion. for how long will it be stable, and what sort of problems along the adjustment curve that this patient is going to go through? And for how long have you followed this case? Yeah, thank you very much.
You're welcome. Great question. First, before talking about relapse, we need to know what exactly we did and what we expect to happen. So what I did, usually, unfortunately, when we look at the case, we start looking at the sagittal and the problem that he has, anterior crossbite. But sometimes it's a gift for us that if we can open if he's deep bite, and they could have the chance to open, as you see, he doesn't show any of his upper anterior before. So what I did, I tried to open his bite. Okay, this opening, if I open, for example, 1 millimeter, it will give me auto rotation of the mandible. The mandible will move down, changing the malocclusion for me, which will help me to achieve my objectives. So what I changed, it's a small changes that I did. I tried to place a bite block, posterior bite block, to open the bite, and then the lower incisor was almost with little changes, okay? And I proclined the upper, slightly proclination, which gave me a chance to retrocline. I have some space in the lower, change it, and then I remove the bite block and try to extrude the upper down and slightly the lower teeth. So talking about relapse, it's about if you really did a big or extend your movement or your tooth movement beyond what we know, or to beyond the right position. So small changes could do for you a big and a great result.
For how long this patient will tolerate the new position that they are at? Because all we know that muscles and tendons will later on always recede to the position that they were at. So close monitoring and close follow-up for such cases is so crucial for their success, and I
Yes.
bet that you are definitely doing that.
Yes. Other thing, by the way, the patient, how he looks now, it's not the normal for him. So we take him to the normal without forcing the tissue or the teeth. I always see relapse if you are forcing the teeth or the bone to the wrong direction. It will try again to go back to its original position. What we did here, we put it in the right place that he has, slightly movement of the teeth, thinking out of the box and changing the smile of this patient.
Because always, like occlusal contacts evaluation and occlusal contacts maintenance definitely will need to be like mounted on fully adjustable
Totally
articulators and followed for long. Thank you.
Yeah, right.
Thank you. Maybe we have a chance for one more.
Thank you very much, Dr. Wander. My question is about the unilateral posterior crossbite. What was your retention routine you used in that one?
Unilateral
open bite.
The retention was wholly retainer with some, this is a good question, I placed some acrylic, extend the acrylic on both sides, trying to prevent the tongue and slightly the cheek until we get some intercuspation of this case, and follow up the retention for this kind of cases. It's like continuing with your treatment until you see everything is fine with this patient.
So was the tongue thrust a cause, or was it, I think?
He did not mention any habit that he was doing. We never know what happened earlier, so of course if the tongue find the space when swallowing, he try to push the teeth, and of course will prevent the normal eruption of the teeth.
Thank you very much.
You're welcome.
Once again, thank you so much, Dr. Vander, and the organizing committee would like to thank you for your outstanding contribution by giving you this appreciation certificate.
And our last speaker is Dr. Sarah Mubaraki. Dr. Sarah graduated with a bachelor and master degree in periodontics from Riyadh Al-Ilm University. She is currently working as a lecturer in periodontics, and she's a clinical director and director of admission and registration for female student affairs. Welcome, Dr. Sarah.
Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone. I would like to thank the organizing committee for giving me this chance to stand in front of my mentors, my seniors, my colleagues and my students. Actually, I'm a pediatric dentist, I'm not a periodontist. That's why I choose this topic, dental fear and anxiety in a non-pharmacological approach. I won't talk about dental treatment modalities, placing restoration or placing implant type of impression materials or so. No, I'll talk in another direction, how you can convince your patient to sit in a dental chair. I can tell that I'm one of those uncooperative patients. Really, I can remember years ago I went to a pediatric dentist in Jeddah, and he was convincing me to open my mouth because he needed to extract one molar for me. I remember very clearly that he's telling me that imagine you are having 10 fingers and I will pull out one of your fingers. And seriously, this is the way how you are convincing me to open my mouth? I cannot remember if I opened my mouth. I don't know if he could manage, but I don't think so. It's generally known that people develop specific fear as a result of learning. And to understand the statement, I just want you to remember a very well-known experiment has been done many years ago called Little Albert experiment. Little Albert experiment was a child who named as Albert. He was 9 months old, and they exposed several stimulus to this child, and the child shows no fear. They introduced for her fire, monkey, dog, and rats. Later on, after few months, the white rat was placed near to the Albert, and they allow him to touch it and play with him, and also he shows no fear. Later on, they linked the rat with a loud voice, and when the loud voice starts coming, the child starts screaming and crying and refuses to sit. And later on, they exposed the child only with the rat. The moment he saw the rat, he starts screaming and crying because he was waiting for the loud and the noisy voice. There is a half-century ago, Walter Buchanan found in his experiment that there is a connection between emotion and certain physiological changes in the body. And most of us, we have fearful feelings, we have different level of anxiety in our daily life. And just to understand what is going on inside our body, I just want to remind you very quick about physiology and how we develop this fearful feeling. So hypothalamus is the master controller. It's worked as a link between our brain and body. It's located somewhere in our brain. So when there is any sort of danger, patient seeing injection or hearing loud voice, so the hypothalamus would immediately send signal, so adrenaline will be produced. Adrenaline will go to the muscles, and the muscle will start responding by fight or flight. So as much adrenaline was produced, as much fearful feeling we will have. And like me now, I have a certain level of fear because I'm presenting in front of everyone. I can tell that I have more respiration rate, more heart rate, and more blood pressure. And usually we feel that the blood is shifted away from stomach and intestine, going to heart and central nervous system. That's why always we said قلبي طاح أو قلبي في بطني because of this process. The term of fear and anxiety used interchangeably, and they are much related to each other, but they are different. Both they are involved psychological, emotional, and cognitive component. Dental anxiety is an emotional state which precede an encounter with feared object or situation. Dental fear refer to actual or activated response to object or situation. Dental fear or anxiety may be described as a subject state of feeling or reaction to a dental source of danger. It's unpleasant mental or emotional or psychological sensation derived from a specific dental-related stimuli. And within few slides, I will go through this in depth. Fear of dentist has been ranked in many studies that as a fourth among common fear. Dental fear and anxiety are primarily the reason why many individuals avoid seeking oral health care, and yes, I'm one of them. Most of us consider dental fear and anxiety to be an extremely relevant dimension to our practice. Sometimes we feel exhausted, sometimes it takes a lot from us just to convince those patients to sit on the dental chair. Many studies have been conducted to show the prevalence of dental fear, and very few studies has been conducted in the Kingdom of Saudi Arabia, and this is area for research. Dental anxiety affect adults within 10 to 20%, and children and adolescents range between 5 and 20%, and you can see there is no difference. One study has been conducted recently in 2014 in Jeddah. They found that 23% of Saudi children, they have specific level of dental fear. Dental anxiety vary by type of treatment. Yes, periodontic and endodontic treatment get the higher rank of anxiety because always the patient, they will go to endo and perio complaining from pain. Usually this is in adults. Dental anxiety among adults in Saudi Arabia is 27%. In female Saudi adolescents, 25 to 27%, which is very high. This study was done recently in 2018. You can see the most common causes or most common reason why people they are developing the dental fear. Injection was number one, followed by the drill, the sound of the drill or the vibration, and the patient was afraid for shocking. And yes, injection, I think most of us we are afraid of injection. We like to give injection, but we don't like to take it. Other study has been conducted to show the dental anxiety and sex of the patient. Yes, females, we are higher than male. We develop anxiety and fear more than male in most of the studies. Higher anxiety level. I found one interesting article. What they did, they evaluate the anxiety for the pediatric dentist, not the patients. Yes, we have an anxiety. Sometimes we are afraid to injure the patient. We already have a toxic stress. We don't know how to manage. Yes, they did the study for a pediatric resident, master degree, PhD degree, and board resident. And they found most of the female and male, they have more than 50%, they are having an experience dental fear during the procedure. And if you can see this diagram, the pie chart shows that most of them, they are concerning about failure to interact with the child, apply behavior management technique with a high percentage. I was going through Twitter and social media, and I was like, what is this? Really? We are monsters for them? Yes, we are. Most of the people on Twitter and Instagram, they are posting very bad things about us. Some I can post and many of things I cannot. Yes, many of them, they said that very frankly and very clear in our faces that really we hate you, Doctor, أنا أكرهك. I cannot tolerate the smell of the dental chair, the smell of the dental environment. I cannot sit on this chair. The etiology was discussed in many studies, and there is 4 main reasons was very studied extensively. They found pain or unpleasant experience was one of the most causes for dental anxiety. Studies shown that previous surgical experience adversely influenced the behavior. Yes, female remember their painful experience and report more anxiety associated with dental treatment than male. Traumatic experience. Yes, that's why we are here. What we build today will reflect later on. A high anxiety and some of the parents, when they have a traumatic experience, they transfer this experience to their children. That's why many of the parents, when they come to your clinic, they said, sorry دكتورة, but أنا أخاف من طبيب الأسنان. بنتي طال عليا. This is fact, this is there. General behavior problem and mood complex. There is a relation between general behavior problem and dental behavior management problem. Children who have difficulty focusing and attention and or adjunct activity in their general environment has increased problem. Perception of unsuccessful treatment. Many patients who already have unsuccessful treatment with other dentists, they are concerning and they are afraid and they have certain level of anxiety to have another unsuccessful treatment. Parent influence and early preventing care is very important. Parents influence their children's behavior at the dental office in several ways. And I can remember one of my friends, she told her son that you cannot get to the plane without removing your moving tooth. So he took from him only 1 hour to remove that severely moving tooth so he can travel to England. Early preventing care leads to less dental disease, decrease the treatment need, and fewer opportunity to a negative experience. Cycle of dental fear. Dental fear always come at the top. If the patient is having dental anxiety and fear, so usually they will delay and avoid the treatment. So many cancellation, many failed to come. So many complications, longer treatment, complex treatment. Instead of doing simple restoration, you will go for root canal or you will extract many molars or teeth. We are like most of the other countries. We do not have a referral pathway for patient and identify with a fear and an anxiety. The need to receive psychological treatment in a non-dental visit for patient with high level of anxiety donates who specialize or interest in treating such patient. That's why most of the other clinician and the other specialty, they always transfer their patient to pediatric clinic. And sometimes we are suffering, we don't remember how to do root canal treatment. We are not genius in that. We don't have the skill. We already focusing in another branch of treatment. I just want to share, this was very famous in social media and WhatsApp, that yes, this is what they said, that لو لقيته بقى يسلم عليك بإيد ويطبطب عليك بالإيد التانية يبقى ده بيدو. Yes, ونطبطب على patient. Yes, we hold our patient's hand. Yes, we give extra time. Yes, we are trying our best to convince those patients to promote a positive behavior in dental chair. Always remember the key to the successful outcome and appropriate assessment of the child and family to prepare them to participate actively in a positive manner in the child oral health care. Today children, they are different than before. Today they are more exposed to the media. Today they went to the school earlier and they are more aware. Our aim is to effectively perform treatment and to improve and to have a positive dental attitude. Our aim to give high quality dental care and positive attitude is an integral part of our practice. Pain has been directly influenced on a behavior. If you have pain sometime, you don't want to go to the dentist because you experience this. Fear of a dental treatment is prevalent and have an impact on the quality of life and the quality of dental treatment. Establishing a good team, starting from the reception and with you as a dentist. And what I'm saying today, it's not only for a pediatric dentist, this is for everyone. If the patient will not sit in your dental chair and open your mouth and cooperate, you will not give and you will not deliver a high quality of treatment. So always smile. It does not take a lot, but it does a lot. Smile every time. Smile to the receptionist, smile to the assistant, smile to the patient and parents. Call the patient with his nickname, and if you don't know his nickname, create one for him. Talk about something in common. Talk about the school achievement, games, al-ahli, al-hilal, what is common. Tell the female child that you have very nice dress, your hair is very nice, don't go and cut it. Always remember that children are unlike the adults. Most children see things either black or white. The shade in between they cannot. It's very difficult for them. So always be flexible. Establish a relationship between you and your patient, between you and the child, based on trust. If the child will not trust you, he will not sit on the chair. Give a positive impression. Smile, smile and smile. Look at your patient while you are talking to him. Don't mix a material or talk to assistant while the child is talking to you. Be flexible again. The child lack of maturity. Ignore the misbehavior. Push the patient forward. Give a positive remarks for him. Tolerance. Tolerance is not always for the patient. Tolerance always for us. It refers to the dentist's ability to cope rationally with misbehavior. You have to know your mood. If your mood is good in the early morning, so book those patients who need extra time, extra effort in the early morning, so you can give more. The most potent agent in managing and management of anxious patient is therapeutic use of physician-patient relationship, as I said. This is one of my patients, and always when I'm treating him, I said, you are Batman, you are a very strong boy. I'm very happy, I'm very proud I'm treating you. You will be my dentist one day. And every time he come to my clinic with a different custom. Always build this confidence inside your child, inside the child, inside your patients. Communicate. Communication is very complex and multisensory process. To improve the clarity of the message while you are talking to the young child, use a very simple word. Don't use the dental and medical words while you are talking to the child and the patient. Use very simple word. Don't take too much while you are talking to the patient. Sudden and firm commands, which known as voice control, it's very important. Use voice control just to grab the attention of the child, not to shout. We are not here to fight with the patient or the parents. We are here to serve the patient. We want to deliver a high quality of treatment. So changing the tone of your voice will help a lot. And you have to inform the parents that you are not shouting. This is one way to managing, because me as a sister or a mother, I will not accept one to shout or to change his voice for my kid. Non-verbal messages can also be sent for the patient, and you will receive for them. Sometime when you finish the procedure, the patient starts coming, running to you and hug you. He shows that he's happy and he likes you. So use your hand, touch the patient, communicate with him. Body contact is very important in communication skills. The dentist simply acting with the child. Don't talk to the child while you are standing. Just go below and talk to him. Put eye-to-eye contact. Always, and sometimes we forget that we are guiding the behavior of the child, and that always by sending you messages. You stop talking, you stop talking, stop moving your tongue. You stop that immediately or I will not treat you. Replace it by I. Always you message have been termed in literature as a rock block to communication. So replace it by I message. I can fix your teeth if you open wider. I can give you more treatment and I can give you a relaxing environment if you help me, if you cooperate with me more. And be active listener. Yes. We have a lot of patients, we have a lot of things outside dental environment, but yes, we need to give extra time for the patient. We need to listen to them. When they said they are scared, yes, they are scared. So give them few minutes and re-talk with them and give them extra time. Always in literature and the articles and our references, we heard something called behavior shaping. Behavior shaping is a type of learning. It's known as a procedure which very slowly develops behavior by reinforcing successful approximation of the desired behavior until the desired behavior occurs, until you get the fruit and flower at the end. So it will take a lot of time from you, it'll take a lot of efforts, yes, but at the end you want to get this fruit. So it can come by explanation of the treatment for the patient, for the parents. You spend more time. Tell, show, and do. Till now we use it. Also we use it with adult patients. And reinforce the good and positive behavior. Always remember, behavior shaping is regarded as a learning module. Adverse conditioning. Adverse conditioning is known as hand-over-mouth exercise. Its main purpose is just to grab and gain the attention of the child. Usually we don't use it a lot, but it's there. Some of the dentists, some of the physicians still they use it, but it's not very common in dental practice. Parent-child separation. There is an anxiety and there is there is certain level of anxiety and fear because of parent separation. But as the patient gets older, this anxiety will be less. Today, parents actively participate in the clinic, but sometimes the child is independent and they don't need the parent to sit on the dental chair. So it will be more flexible and more better for us as a dentist to allow and to ask the parent to sit at the dental in the reception area. It's very important to know that pre-visit preparation is very important. They can do it, the parents at home or you in the waiting area of the clinic, by putting positive images or open video for the child. Direct observation, allow the child to see when you are working with a very cooperative patient. And this will do a lot, and you can see it with time. Memory construction. Memory construction based on usual positive image to help reconstructing memory of dental treatment by many types, by four types. The first one is the visual component. Picture taking to a previously child is accepting and happily was taking the treatment. Verbalization. The child was asked how she would explain this to the parent or to the friend. And third one is the provision of concrete example. Sorry, I need water. Provision of concrete example. The child asked to recall a good example for any previous treatment that he was so good in that appointment. And this will lead to the fourth one, is the sensation of accomplished. And yes, you feel happy, the patient feel happy also, the parents. Ask, tell, and ask. The patient visit and feeling toward and about any planned procedure. This is ask. And explain the procedure by demonstrating, explain it to the patient and the parents, and again inquiring if the patient understand and how she feel about impending the treatment. Distraction. Every one of us like distraction, and distraction work properly and nicely in the dental chair. You can distract the patient by short break during the procedure. After you finish preparation, you can ask the patient to have a few minutes break. You can distract the patient by using iPad, videos, or the videotaped glasses. So many ways to distract the patient. Sometimes we distract them by singing, and I do this. I have the worst voice ever, but I sing. I would like to share one case. She was one of my best patients, and she's my friend now. Mariam, she's 4 years healthy child. She had no history of hospitalization or allergies. She had never been to a dentist before. She is a very negative and her behavior was very negative. She's an uncooperative child. She don't want me to touch her even. And the first visit was only for clinical photographs. I show her this is only camera and those are mirrors. I take extra photos for her. I show her some of my clinical cases before. She refused. In the beginning, she was uncooperative. She accepted and she refused. And it's take a lot of time, or around 30 minutes, just to take photos. And we successfully took those photos. For the second visit, after 1 week, we took only radiograph. I show her the sensor, I show her the camera, and I did a demonstration for her and her mother and sibling, to show her the way how I took x-rays. She was uncooperative. She accepted the treatment for a few minutes, then she refused back again. And we took the x-rays. For the third visit, I did only treatment plan. I show her the small mirror. I give her mirror so she can see how I'm counting her teeth, how can I see the cavities, how can we write what's inside her mouth. And she was not accepting to have the dental explorer, and I respect her because she's having an anxiety and she did not trust me yet. So I changed the explorer and I used a dental prop with the treatment plan. For the fourth visit, I show her the low speed and the cup so we can do prophylaxis, and I apply topical fluoride for her. I used the handpiece on her fingers after I did in my own, and she's starting to accept. I told her, if you go and do pedicure and manicure, they will polish your teeth. This is the same. I will just clean your teeth. I just want them to be glazed and nice. And she started to accept. Okay, حجرب. And she accepted and she gave me the chance. And I apply topical fluoride on her finger as they are nail polish, but they are only for teeth. And she accepted finally. For the fourth visit, I did for her fissure sealant for 4 molars, and I could not put the syringe for acid etch and fissure sealant in front of her. So I put drops only on the side, and I use micro brush. I put the acid etch on her finger, and I show her that I will wash it away. Then I'll put the white color. Then I'll put light, so it will be hard and fixed, so your teeth will be more stronger. And she accept, and she start to cooperate with me. In the fourth visit, sixth visit, sorry, I did PRR. I show her the handpiece. It's only a water spray, and it's very strong, so it can remove all the cavity, and it can clean your teeth, and any food in between, I can take it out, so the caries will not come back again. So it took me around 20 minutes, but it was a very successful appointment. I was happy that day. Seventh visit, I could manage, and I gave her local anesthesia, and I did pulpotomy and stainless steel crown for 1 tooth. And she was cooperative. She cried a bit, but she accepted. I think she started to trust me. And I always do something with my patient, that I tell them, إذا أنا فزت and you did not feel any pain, you will give me a gift, and I'm sure I will not spend money to get a gift for you. You will get me a gift, and I will think what gift I want. And it's work a lot. So they, okay, دكتورة سارة ما حتوجعني. And the patient, she was not happy with her teeth because she will go to school, so she want to have a nice smile. So at the last appointment for her, I did for her all the anterior teeth. And this is the day she hugged me very hard. So this is her photographs after the treatment, and I feel really very happy that it took me very long time. I could manage in 2 or 3 visits for any cooperative patient. It took me around 10 visits, but I'm very happy. I convinced her to sit. She opened her mouth. I changed her behavior. I did something for her. So fear and anxiety management, it's not only for children. That's why many of other specialty, they refer their patient for us in pediatric dentistry clinic. New studies is required. It was very hard for me to get studies regarding dental fear and anxiety, especially in Saudi. Very few studies was there, but it's not like in depth like the other studies has been conducted in other way. Many patients do not receive the required treatment because of their anxiety. Advanced behavior management, both pharmacologically and non-pharmacological approach, can help us to improve the quality of care regardless of our specialty. Although the operative dentistry may be perfect, the appointment is failure if the child starts to cry. So my take-home message, once the anxious patient has been recognized and proper diagnosis is made, management and treatment will be easily carried out. Thank you.
Thank you, Dr. Sarah, very much for this informative presentation. I think the approaches that we are evolving nowadays, it's much more convincing for patients. Maybe as well the community has to give a message not to threaten the child by doctors or by any procedure like by injection, because they think this is a punishment. And when they come to you, they are ready for the punishment sometimes. So parent education and culture, maybe it's important as well.
Yes, doctor, I agree. And many of the females, especially the females, know this, that when we are going to any places and there is a lot of kids there, they start, see, she's a dentist, she's a doctor, she's having needle in her back. If you did not sit properly, she will inject you. And the child starts screaming and sit on the side. Yes, there is. So parent education is very important. It should start from our side to deliver this message to them.
You know, in endodontic, we always deal with pain as well. And most of the patients that they have their previous thought or experience or talk with their colleagues or relative about the pain. But we realize that if patient get educated inside the clinic, if you don't wear the regular costume, like not the white coat, like a t-shirt or something, if you keep the patient on control, like if you have any pain, I will stop. I will not do the procedure.
Yes.
You are in control. Always raise your hand and we will stop. That helps a lot to decrease the anxiety and fears inside the dental clinic.
Yeah, I agree.
Now we would like to have one or two questions maximum. I think the
Don't be anxious, you can ask.
Okay. Dr. Hassan.
How many visits to do one procedure for this patient? How many visits did it take?
To start the actual treatment?
Yes.
3 visits.
Okay.
The first visit was only for photographs, and I spent around 35 minutes just taking photos. Second visit only for radiographs. Also it took 35 minutes. The third visit was only for treatment planning.
And the total number of visits is?
Around 9 or 10.
Okay, good.
Yeah.
Now, how would you justify to a clinic accountant that you're going to see the patient for 9 appointments and then produce a certain amount of money out of them? Because they calculate time against revenue, and they'll blame you that you're not an income maker for the clinic, while in reality you're a huge income maker for the whole dental industry, you know?
Yeah.
So we need to talk a lot with our clinic administrators and accountants and tell them that what we do is not only operative procedures, but we are managing even financially the success of this clinic.
Yeah.
We can relate to the value of what you have done, okay? But they don't see that. They say, well, 3 visits, no income? How can we survive like this, you know? Yeah. But in reality, you're making, definitely, you're building income for this clinic on the long run, you know?
Yes.
Short-sightedness is gonna always affect dentistry, whether in Saudi Arabia or anywhere in the world. But when you look further to higher goals, then you've achieved even financial success with that. Thank you very much, Dr.
Thank you, Doctor.
Okay, Dr. Mansour.
السلام عليكم وسعد الله مساكم. لما يقولوا ختامها مسك فعلا ختامها مسك. Dr. Sarah, I'm sure when you are in the schedule the last you have an anxiety and fear. But you proved to all of us that you are really an expert. And فعلا ختامة مسك. I'm always proud of you. Thank you.
Thank you, Doctor. It really means a lot.
So on behalf of the Scientific Organization Committee, we would like to present certifications of appreciations to our chairman for this afternoon, Dr. Khalid Mirdad and Dr. Abdullah Al-Barhi.
Yeah, was our last lecture for our scientific program in our conference this year. We will have a break for 15 minutes. At 3:45, we will have the awarding and announcements for the posters competition, IDR competition, and the Saudi Dental Education Society competition. So don't miss it, and we will see you at 3:45.
Assalamu alaikum. Welcome back. Now we will start the closing remark with the speech of Dr. Muhammad Al-Rafi'i, the Dean of College of Dentistry and the Chairman of the conference. Welcome, Dr. Muhammad.
Yes. The story is about to end. Thank you for being with us again for the third day. It was wonderful conference. We are so happy, so excited, and on behalf of the organizing committees, we are happy to have you. Or on behalf of the Riyadh Al-Ilm University, we would like to share some few words that we were preparing this conference. It took about 3 to 4 months to do that. It was a big number of students contribute in this conference, and this is the beautiful part of this conference. It takes times and effort. We were so tired, so many difficulties we faced. But when the conference started, we saw people coming and excited. That put more energy in us to be excited as you are. So in this 15 minutes, I will try to give the mic to you to give any comments, questions, remarks in regard to the conference, so we could take it and consider that in the next meeting, inshallah. So we would like to have the mic around to have 10 minutes of your comments. So we may start with the female side.
I was very, very impressed with the conference for the sessions I attended, and I wondered if it would add to the value when you have guest speakers, both from within Saudi Arabia and outside, who are senior researchers and educators, that you could have a roundtable mentoring session, so that in the lunch hour you can have a group of students or a young faculty and a senior faculty mentor sitting with them eating lunch and sharing ideas and answering questions. That oftentimes adds a very valuable dimension to the meeting.
Very great suggestion, and we'll take it in consideration. Yeah, I'll not be answering everything. I'll take these comments and we'll consider it with the next event that we're going to have. And the meeting that we have, we try to flavor it. We would like to please everybody. Some people would like more clinical, some people would like research, some people like education. That's why we had this effort together with the Saudi Education Society. But with this comment, we will consider it, inshallah. We have any more comments or? Yes, please.
Good afternoon, Dr. Muhammad. I would like to thank you and congratulate you for the successful conference. It was a very impressive conference, and I was really interested, many successful speakers at the conference, and I was really interested with Prof. Karen's lecture, because it's really the concept of professionalism that we need to embed with our new generation. And yesterday, the mini talk concerning the postgraduate, it was really interesting. I would like to congratulate you concerning this conference. It's really organized, well organized, and really successful. Thank you so much.
Thank you for your kind word. Thank you. Male side. Dr. Wasim. Do you mind to introduce yourself so people will know you?
Sure. Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Wasim Radwan. I used to be a student, and I went to abroad, and I came back, and now I'm a faculty. I'm an assistant professor in Okay. So I'm a faculty and assistant professor in the restorative department. I might share a very good fact that yesterday we raised 278 numbers of students from the organization committee that they helped in assisting those professors and speakers. And I'm actually, as a student, I'm a former student, and now as a faculty, I'm quite honored and pleased from the success. And I want to raise this gratitude and congratulations to you, Dean Muhammad, and Professor Abdullah Shamri, and the colleagues and deans, and this is such an honor and pleasure to be such a successful, let's say, conference. And it's following the guidelines of Vision 2030 from these kind of speakers, from the scientific committee as well. So I would like to, let's say, give a warm applause to these students who helped in successfully helping this kind of conference. Thank you very much.
Very true, Dr. Wasim. This is true. The real soldier are our students. Really, we are here just to do the coordination part of it, which is easy part, but the real and hard work is done by our students. We are happy about that. And actually, there is also training part in doing such conference. We are training our students to be leader in this. So they contribute, then they will supervise, then they can do it by themselves in their own institute later on. And this is going to happen, inshallah. Any more contribution, comments? Maybe you want to finish early, that's what I think. Anybody from the front line? Dr. Hassan?
Assalamu alaikum jami'an. After attending the first meeting of Riyadh colleges then for dentistry and pharmacy, and now we're reaching the 11th meeting. I feel so very compelled to thank Dr. Abdullah Shamri and to thank the organizing committees, to thank Dr. Nasser Shamrani and Dr. Mansour Asiri, yourself, Dr. Muhammad, and all the colleagues, that if I miss anyone, I would not be appreciative enough for your efforts in achieving this. When I first gave a presentation to the dental implantology fellowship program at the university, at Riyadh Al-Ilm University before, I said one word, that we, the body of dentists and the society in Saudi Arabia, is in need of this university more than the university is in need of us. The years pass by, and it proves that Dr. Abdullah and Riyadh College, Riyadh Al-Ilm University, is now in the leading role for developing newly graduate dentists and also newly trained professionals and specialists in all fields of specialties. I cannot commend you more than this. I thank you very much for all your efforts over the years, and will keep on coming here to learn more. Every day we learn more, and we learn from each other and from our young, energetic presenters and professors, as much as we learn from our professors and educators and mentors before. Thank you all.
Thank you so much, Dr. Hassan. Thank you. Any more?
Assalamu alaikum. Dr. Sultan Malki, Vice Dean of Quality and Development in College of Dentistry, Prince Sultan University. I would like to take this opportunity to thank you all the organizing community, all the professors, speakers. I have enjoyed the last 3 days, brilliant organization. One comment, if I would add, is the idea of combining both the 11th Riyadh International Dental Meeting and the second Saudi Dental Education Conference. I found it is a brilliant idea. I remember in the first meeting, the idea that the harmony that I saw in this event was really good. The participation of both, we have two different targets, but the harmony was really good. So I really encourage you to continue doing this sort of combination. My interest is the dental education, but I benefited a lot from other other specialists who came also, and I believe they also benefited from coming and sharing the knowledge and the skills and the know-how with the people who are interested in the dental education. So I encourage you to continue this brilliant cooperation, and I thank you all, Prof. Abdullah, you yourself, and Dr. Mansour, and Dr. Saleh. Thank you very much. Thank you.
Thank you, Doctor. Thank you, Doctor. This is really the tradition of the university. This is not the first time to be done like this. And if you go back to this is 11th, but most of these done in combination with others. There is a series of meetings and conferences done with the contestants, and one of the, also with the Ministry of Health, and now with the Ministry of Education. So now this is the new trend nowadays. There is so many meetings, so you need to flavor your meeting with something to attract people. We'd like to attract people, so to give the message, to deliver what you want to deliver. And I can promise there will be more kind of combination in the future, inshallah. But we'll flavor it differently most of the time. Yes. They gave me 10 minutes, so I'm going to fill that 10 minutes. So I'm not going to stop until that 10 minutes finished. Maybe there's one more or two more. If there is nothing from your side, I just speak on behalf of the organizing committee that, yes, we try to do our best to serve you, and we are so happy and honored to serve you, but always there will be some sort of difficulties, negative issues. So we apologize if anything happened. I would like, if anybody find it difficulty to say some comments, you just write it down and send it to my email or anybody at the university. So we apologize if anything, but we try to do something different this time, that we put the meeting and the conference within the campuses of the university. We think this is a good success, but some people felt that that's different from usual. But we felt that going to a hotel or other places, it will be difficult to be able to go there. The place is not us, it's not our place. So, but coming to the campus itself, our campus, we could do more things to serve you. So I'm waiting for more comments through the email, and thank you again, and we're happy to serve you. Thank you so much. Now, I'm not going to end now. I'm going to call the Prof. Abdullah Shamari, the chairman of the conference, and the Dr. Prof. De Souza, and Dr. Tissam to come to the front and to award the winners. So I would like to call you. Prof. Abdullah promises me to give me 5 minutes talk.
Dr. Mohammed. Dr. On behalf of the Saudi Dental Education Society, I would like to thank Professor Abdullah Shamari and all the organizing committees that were working with us side by side for the past 4 to 6 months to try to prepare a conference that equally combines and aligns dental education with clinical side as well. We all know that as young dentists, we come in with the requirement and need to take a look at a lot of skills in dentistry, but at the same time, we need to discuss how we educate our young students and faculty. And when we approached Professor Abdullah 6 months ago to discuss this perfect collaboration, we were very happy to find Dr. Abdullah very willing and very supportive, and Dr. Abdullah Shamari has been supportive of dental education from a very long time ago. So I think this was a perfect partnership, and we're very happy that they have aligned with us and partnered and hosted this event and done this perfect organization in their campus. So on behalf of the society, we'd like to thank you very much, and we hope inshallah we will have a lot more collaboration in the future. Thank you.
see if I can. As the president of the International Association for Dental Research, I extend my heartiest congratulations to the organizer, the organizing committee, and especially the student hosts that looked after all our needs every minute of our stay. So thank you. I leave my first visit from Saudi, hopefully not the last visit, taking many warm memories back, and also the dream that this country and this school and its fellow universities will lead, emerge as strong leaders for the entire Middle East region. I feel that you are in the best position to do this with excellent support from your leaders and a very talented group of faculty and students. So this is a dream I will take back and I will wish to come true in the next few years. So we stand to help you in any which way possible. Thank you for making my stay a very happy and memorable one. Thank you.
Assalamu alaikum. Good afternoon. Thanks for you, Dr. Sunuza and Dr. Abtisam. And as you said, I mean, the thanks will go for our great students and their supervisor who worked so hard, I mean, to make the success of this meeting. And again, as Dr. Abtisam talked, this is the second Saudi dental education meeting with our 11th, I mean, Riyadh dental meeting. We concentrate mainly at the education. And the first one from dental education in any dental school, you like to train, I mean, the current students to be the future of the leader. And there will be no better training than to be involved in such a meeting like this. So when I hear from our guests from time to time how our students, females and males, they are willing to serve, to participate, to do everything. All of us, we feel so happy and also looking with a positive, I mean, vision for the future. Yesterday at the discussion, our colleagues from outside Riyadh, they raised one important issue for me as a concerned person, that they said other dental school, maybe there was no chance for their students to have the same, or what we call it, I mean, equal chance. Yes, this is a fact. Always there is a variation, but I am sure, as Dr. Abtisam, leader now and head for the Saudi Dental Education Society, which is responsible, I mean, for all dental education in the country, we like to cooperate with her from our side at the Riyadh Al-Ilm University, and I wish and hope also the other deans, which we feel proud that all of them, they came for our invitation and they attend here. They will, next Saudi Dental Education meeting, whatever the place, here or there, we like to see a group of the dental students from different dental school participate, I mean, in the meeting and learn and share the knowledge, I mean, the way how we just practice it here. Yeah. So I like really to thank Dean Muhammad Al-Rafi and all of his member of the committees, and also the Dean Ibtisam Al-Madi, and here also Saudi Dental Education Committee, and all the members. I cannot name it because yesterday, maybe in the final ceremony, you already noticed how many they are involved with us. But I'll tell you our habits. I mean, next week, as a habit for the last tens, I mean, conferences, we organize a boss conference, I mean, thanks and appreciation for those students, faculty who work with us. Because for us in this university, before in this dental school, this is the main target for us, I mean, to thank them and to discuss with them so many achievement, positive thing, and as Dean Al-Rafi, caring about negatives, because we must have negatives, we must have short income. Without this, we cannot improve. But the most important thing, we don't like to repeat the same mistake. We did it, for example, in this conference when we plan for the next year conference. So we have an excellent documentation, by the way, and for your information, we have a complete quality assurance committee with more than 25 members working in all of our activities, and they will send the surveys for all of you. All our surveys is also digitalized, doesn't need any paper, and can be analyzed. And we like to look for their reports. I asked them a dead time this coming Monday, because there is no value to delay for the quality report of our conference after we go back for the work by tomorrow, because tomorrow we'll start our activities. There is no excuse even for our young students, because us, still young, but we will come back morning to continue our work as normal without any absent or people after conference. They said, we like to take a vacation. No, we enjoy these 2 weekend days for something, not a traditional day of any university. We felt so happy when we meet most of our colleagues coming from different parts of the country, those distinguished speakers, and guests to be with us. The first time we have the honor, the president of the IDR to be in our country and also in our university. As she promised us, she will repeat this, not necessarily in the capacity of the president of IDR, because I know that the president always 1 year, but she will come to join us in her capacity as distinguished, specialist and educator. And also we hope when she meet, with the IDR division in the next meeting, to transfer some of the memory of positive things. As we are felt proud last summer at London, the Saudi division, was the winner of the best expandable division from the membership. And I think all of us aware that the Saudi division is really growing. It's a good chance, to thank Dr. Sultan and all of the board members for the excellent efforts. I am so happy when those young people, they work a lot. They keep the Saudi division in their daily work as the first priority. I never saw this, frankly, among my senior colleagues. Many times I have disappointed, response when we call for certain meeting. And this is confirmed my philosophy, always give the young, guide them, and you will see something, unbelievable. So thanks for all of you. And we wish, to see you again, in the next activities, within our country in general, and Riyadh al-Ilm, specifically. And thank you. Yeah.
Okay. Thank you, Prof. Abdullah. Now we'll start our award session. Okay. We'll start to thank the member of judging committee. We really appreciate your efforts during the evaluation. Dr. Dalal al-Qahtani. Dr. Johariya Sadat. دكتور سمر الصالح. دكتور سمر الصالح. بروف أشرف كامل. بروف سناء شبشأ. دكتور فيصل الخيال. دكتور سارة أبو ريسي. دكتور سنيل بابو. دكتور تغريد العوهلي. دكتور عبد الله الحواس. دكتور مساعد التمامي. دكتورة فهدة الدهش. دكتور محمد عبد البصير. دكتور دينا الشريف. دكتور محمد الحارثي. دكتور نادية العنقري. دكتور وسيم رضوان. دكتور بندر اليامي. دكتور ناصر القحطاني. الدكتور ركان شاهين. Thank you. Now we will start to announce the Junior Poster Award, starting from the 5th place, Maram Abdullah Dosari, entitled EGCG, Effect on Nicotine-Induced Streptococcus Mutans. Fourth place, Noura Saif, Light Intensity Output of Epilepsy Unit and Clinician Knowledge. Third place, Athir Ibrahim Alwanin, shear bond strength of self-etching compared to conventional acid etch adhesive system of orthodontic bracket bonded to permanent premolar in vitro study. Second place, Mahal Mutlaq, prevalence of pulpous stone and its correlation with systematic disease using digital radiograph. And the first place among junior poster award for Dr. Ala Al-Ahmadi. Maxillary sinus stimulation and associated factor in Al Madina. Dr. Ala? Yes. Welcome. Yes. Okay, now we will go for the Senior Poster Award. The fifth place for Noor Al-Gahtani, Dr. Noor Al-Gahtani, antibacterial effect, acidic nitrogen extract on endodontic microorganisms. Dr. Nora is here. Yes. The fourth place, Dr. Turki Al-Mtairi, replacement of distorted dentition of the cone beam computed tomography scan of orthodontic surgery planning. Third place, Dr. Mirfik Ali. How does poor oral health impact the academic performance of the school children? A pathway analysis using a structure equation modeling. Okay. Second place, Dr. Ziyad Al-Hammad. The prevalence of severity of maxillofacial fracture resulted from MVA. And the first place among the Senior Poster Award for Dr. Muhammad Al-Anizi. Histological and micro-CT evaluation of regenerative repair experimentally in large mature root apex of necrotic dog's teeth with apical periodontitis. Now, we will go for the Saudi Dental Education Society Award. Start with the Junior Saudi Dental Education Society Award. The third place for Dr. Sumaya Basudan. Practicing evidence-based dentistry among sample of dental practitioners in Riyadh City. The second place for Dr. Nasser Al-Ghifali. Quality and readability assessment of web-based information in common prosthodontic treatment. The first place for Dr. Rand Saif. Depression and anxiety and stress among medical and dental students in King Saud University and their life satisfaction, a cross-sectional study. رند ايه تفضل رند Now we will go for the Senior Saudi Dental Education Society Award. The third place for Ala Sharif. The use of a blended teaching learning tools, the introduction of e-learning through WhatsApp. The second place for Dr. Sultan Al-Malki. Influence of motivation on academic performance among dental college students. And the first place of Senior Saudi Dental Education Society Award for Dr. Ambreen Azzam. Uptake of modern technology for learning, a game changer in dental education. Now we will go for the Junior IADR Saudi Arabian Division Award. The third place for Dr. Hadir Al-Dali. Dentist willingness to report suspected violence case in Riyadh region. The second place for Dr. Ahmed Turkestani, comparison of the mechanical properties of recent lentifial and nanohybrid composite. Dr. Ahmed Turkestani. And the first place of Junior IADR Award for Dr. Mnira Al-Madris. Job satisfaction, general health and burnout among dentists in the Eastern province, Saudi Arabia. Okay, finally we will go for the Senior IADR Saudi Arabian Division Award, starting with the third place for Dr. Salma Khatir, entitled of Non-Invasive CPIT Assessment of Micro-Leakage and Restored Class 5 Cavities. The second place for Dr. Rawan Al-Atiq, the effect of Listerine and chlorhexidine mouthwash on the tensile strength selected absorbed sutures. And the first place for Senior IADR Saudi Arabian Award for Dr. Fatma Mtawa. The effect of silver diamond fluoride on the shear bond strength of composite resin to primary enamel. Thank you very much for your attending. We hope you enjoyed the conference. We really appreciate your coming. Thank you.
يا خلاص يا اورجنايزيشن اي احد من الشباب والبنات اجلسوا هنا شوي بس. اوكي اورجنايزيشن خليكم شوي بس.